who has done all the work actually, completely. So very experienced and able to go through all the problems that came across. So we are really looking forward to a packed program, very, very interesting abstracts. It was difficult for us to choose some for posters, so as many as possible have been chosen for oral presentations. So everybody, best of luck, all the best, and we will be judging as we have to. And so I'll hand over to
Thank you very much, Professor Vaidya, for chairing the organising committee, and a huge thank you also to Sean for making everything work like clockwork in the background, and of course to all of our student co-organisers of this symposium. So my name is Tom Carlson. I'm a Professor of Assistive Robotics, and I'm also Head of Education for the Division of Surgery. So it gives me great pleasure to open the session today, and I just wanted to tell you a little bit about the history of the symposium, if I can get on to the next slide. So this has been growing and going strong for several years. The first, everything okay? The first symposium took place in 2019 out in Stanmore, and it was a very small affair. And the reason that we started it was because our master's students wanted to have a get-together during their project time and talk about their projects and have a bit of a social. So we organised that with students and staff together, and it was a great success. And then our undergraduate students and our PhD students said, hey, why can't we join in this as well? We want to also have part of the fun. So we organised a fantastic symposium in 2020, and then something called COVID struck. So we had to switch to online. And everybody did a really good job, and they presented their work. But the thing that was missing was getting together in person. We were missing having the conversations, the coffee breaks, the networking, and that is a hugely important part of the symposium. So a massive thank you to everybody who has managed to circumnavigate the tube strikes today and actually be with us in person, and I'm sure there will be other people joining later as well. That said, we are streaming live on YouTube as well, and the recording will be available afterwards, so those who couldn't make it in person can still see what's going on. This is also an incredibly important year for UCL, as I'm sure you've heard. It's our 200th anniversary, so our bicentenary. And so you talking in the presentation, in the symposium today, you're being part of an incredible piece of history here. So it marks 200 years, not just of education, but of research, and most importantly, having impact on society through that education and research that we do. Hopefully you've enjoyed some of the exhibitions and events that have been going on as part of UCL 200, and this, again, is one of those events. So, a quick overview of what we can expect today. We've started, we will kick off with the undergraduate presentations when I stop talking in a couple of minutes. And then we're delighted to have Professor Mark Emberton joining us. He was the previous Dean of the Faculty of Medical Sciences for 2 terms. He's also a world-famous urologist, so his diary is incredibly packed. So we're really delighted that he's been able to join us today. And then we've got an incredibly important part of the symposium, that's the lunch break. So during that, I suggest that you try to talk to somebody who you don't know, who you've not met before. So maybe you've seen them present something, or maybe you want to go and look at some of the posters that you're interested in, and try and meet a new person, have a conversation, and that's what today's all about. After lunch, hopefully you'll be nicely refreshed for a session with our postgraduate taught students, so our master's students will be presenting. Then we'll have a quick coffee break before going into our PhD student session. So you'll gradually see how research evolves from undergraduate all the way up to postgraduate research. And then there'll be a quick break, and then the end will be an award ceremony. So awards are also important. We've got Best Undergraduate Presentation Award, the Best Postgraduate Taught Presentation Award, the Best Postgraduate Research Presentation Award, and also the Best Poster Award. So we've got lots of teams of judges who will be judging throughout the day. But even if you're not presenting, you can take part as well, because we've got the People's Choices Awards. So later on, you'll get a QR code, and you'll be able to vote for your favourite presentation and your favourite poster as well. So this is, we'll go through these are a list of all of the presenters, and we'll look at those as we go through. I just wanted to say one other thing. So Sian tried to pull together the common themes of today, and what you'll see is that we've got so many different themes, both from pathologies that we're tackling, techniques that we're using, and methods, but there is something that unites every single one of us in this room today, and it's the fact that we're all trying to make people's lives better. So we're trying to tackle different diseases, and we're trying to maybe understand how they progress so that we can create better treatments or prevent people from getting those diseases in the first place. And we use a range of different techniques, from basic lab science to systematic reviews to engineering, and then actually more clinical practice as well, and developing and evaluating the effectiveness. So lots of different topics to talk about today, but just think it's all about making impact and improving people's lives. So without further ado, I'm going to pass over to Davide, who's going to be chairing the undergraduate presentation session. I hope you enjoy today. Thank you.
Good morning, I'm Davide Maffei. I'm a PhD research student, and happy to chair the first session. So the first speaker I'd like to welcome to the stage is Natalia Acemola Lopez.
Hello everyone, my name is Natalia Acemola Lopez and I'm a neuroscience student from the University of Exeter. This year I've been undertaking my professional placement year here at UCL at the Institute of Sports, Exercise and Health. And my supervisors have been Dr. Flaminia Ronca and Dr. Uzair Hakim. Before I delve into my project, I'll give a brief description of myself. I love a bit of adrenaline and I love my heart rate being high. I love sports and also do a little bit of everything. My favourite one, as you can probably already tell, is rowing. During my downtime, I enjoy reading a book, the latest Cosmopolitan magazine, or doing what I've been doing for the past year, collecting brain data from surgeons. My project aims to investigate the differences in intraoperative cognitive load between robotic-assisted and conventional arthroplasty. We hypothesized that robotic-assisted arthroplasty would result in lower prefrontal cortex and parietal activation, reflecting reduced cognitive load compared to conventional arthroplasty. Conventional surgery relies on the surgeon's expertise, technical skills, and their ability to make decisions. In robotic surgery, the surgeon utilizes the robotic arm to manipulate the bone whilst gaining information and feedback from the screen. Robotic assistance has increasingly been adopted in orthopedic practice in recent years, and whilst research shows that it alleviates the physical demands on the surgeons, very little is known on its cognitive effects. Therefore, understanding whether robotic surgery alleviates cognitive load is very important. In order to do this, we recruited 4 orthopedic surgeons who specialize in total knee arthroplasty and total hip arthroplasty. We use functional near-infrared spectroscopy, which is a non-invasive neuroimaging device which measures changes in oxy and deoxyhemoglobin concentration in the brain. We recorded these intraoperatively across the prefrontal cortex and the bilateral parietal lobes. We created a naturalistic study design in order to divide the surgery into distinct stages, and we later compared the stages which occurred in both conventional and robotic against each other. In order to analyze the data, we use a general linear model, and changes in oxyhemoglobin concentrations were used as a measure of cognitive load. Contrary to our hypothesis, we found that greater activation in the prefrontal cortex was shown during robotic-assisted arthroplasty. The prefrontal cortex is responsible for executive functions, such as decision-making and attention. During robotic surgery, the surgeon has to put a lot of attention on the robot and also has to make lots of decisions based on the feedback that the robot gives them. Therefore, this produces more cognitive load on the robot. However, no differences in parietal activation were found between both techniques. As you can see in the figure, those areas which show a darker color show greater activation in conventional, and those areas which show lighter colour so show greater activation in robotic. Thank you very much for listening.
Very interesting topic. And a finding. Do you think that cognitive load is a reason for making something interesting? And if you reduce cognitive load, it might become boring. And vice versa, if there's more cognitive load, it makes it so interesting that people are not bothered about whether it's better for patients or not, and do it just because it's exciting?
I think that, sorry, there was a lot of questions in that. I think it's I think the amount of cognitive load also depends on the surgeon's level of experience. However, we have looked into it quite a bit, and it tends to be that surgeons with more experience with the robot tend to experience less cognitive load because they're more used to it. And those surgeons which are just learning the robot and are quite new to it tend to experience a high level of cognitive load.
Okay, thank you very much. Thank you. We'll move to the next speaker. The next speaker is Shreya Kantamneni, and I apologize if I'm getting any of the names wrong. Just as a reminder, as I didn't say that earlier, we'll try to keep the 4 minutes for the presentations, and then we'll have a couple of minutes for the Q&A. Okay.
Thank you so much. Hello everyone, my name is Shreya and I'm a third year UCL medical student currently integrating in surgical sciences, and today I'm looking forward to sharing with you all my IBSc research project. So who am I? If there are 3 things that really sum me up, it's my genuine interest and passion for volunteering and helping others wherever and whenever I can, and my hobby for problem solving, and my curiosity for exploring the latest developments in medtech. These 3 threads are exactly what drew me into my IBSc research project. This year, through helping organise several surgical conferences, including the UCL Global Surgery Conference and the UCL Virtual Academic Surgery Conference, I've been able to gain an insight into the growing role of robotics within surgery and its incredibly fascinating potential in improving patient outcomes. But equally, I've also found myself asking the question, what is the experience like for the surgeons themselves who use robotics within their surgical practice? And perhaps even more importantly, does it impose any additional neuroergonomic demands? So my IBSc research project focused on the comparative function analysis of prefrontal hemodynamic response function across intraoperative tasks in orthopedic surgeons during conventional and robotic-assisted total hip arthroplasty, where the central aim was to characterize the difference in cardiovascular and cognitive load demand of both conventional and robotic total hip arthroplasty approaches across individual surgical stages that were common to both approaches. Now, when we look at this graph, we can see that in the UK, more than 100,000 primary total hip replacements are being performed each year, and driven by an aging population and arguably further exacerbated by the cancellation and postponement of THA procedures during the COVID-19 pandemic, the current overall demand for primary THA surgeries has been projected to increase by 37.7% by 2060. Meaning that there has now been growing impetus to assess the neurophysiological impact of real-time intraoperative stresses experienced by orthopedic surgeons and the anticipated increase in THA caseload in terms of how it may precipitate burnout within this cohort of surgeons in the long term. However, only 7 studies have objectively quantified and assessed how physiological parameters of stress experienced by orthopedic surgeons when performing THA, out of which only 2 studies by Abures et al. And Kaba et al. have looked into specifically how this intraoperative stress is modulated by the robotic-assisted approach as opposed to the conventional THA approach. But they're critically limited by the subjective assessment of cognitive load as a user-search TLX questionnaire, and also another limitation is their reliance on using cadaveric specimens, which the authors themselves have conceded may not accurately reflect the physiological responses elicited in orthopedic surgeons when performing THA on a living patient within a live operating theatre environment. So, therefore, my project aimed to address this gap in the literature through objective assessment of cognitive load, through analysis of real-time functional near-infrared spectroscopy data. And this data was collected from 5 orthopedic surgeons performing robotic and conventional THA. So FNIRS is a non-invasive neuroimaging technique, and in this study it was used to detect the cortical changes in the local concentration of oxygenated and deoxygenated hemoglobin, elicited when these orthopedic surgeons were performing total hip arthroplasty. And the aim was to look at using 48 optodes to shine near-infrared light into the dorsolateral and ventrolateral prefrontal cortex. So the aim was to apply a hemodynamic response function to model the FNIRS data alongside continuous heart rate variability data captured via ECG to capture the cognitive and autonomic differences of intraoperative surgeon stress, stage by stage. And these are my key findings, as we can see on the right. Thank you so much, and I would like to finally say a huge thank you to my supervisors, Dr. Fleming Yaronka, Dr. Hizar Hakim, and also Natalia Azmota Lopez for the continuous support, encouragement, and guidance throughout this project. Thank you.
Any question from the audience?
That's a really interesting question. So my project was focused on analysis of the data, and this data was collected by my supervisor, Dr. Zahakim, and also Natalia Azmota Lopez. So I wasn't directly involved in the data collection. But when I did observe both Natalia and also Dr. Hakim collecting the data, I noticed that one of the key features was optode placement. So to achieve optimum placement, one of the things that they did was hair parting, so making sure to carefully part the hair so that the optode signals wouldn't be interfered by superficial scalp changes, because it has been shown in a study that blood pressure changes can affect the optode coupling. So that was one of the techniques. And also another thing with FNIRS is that hair characteristics and also skin pigmentation can affect the signal. So that's one key consideration which can be further improved in the study. So one way in which that could be optimized is to consider how the optode configuration can be adjusted so that it suits all different hair types and skin types as well in the future.
Okay, thank you very much.
Thank
we'll
you.
move on. Okay, I'd like to welcome to the stage Aisha Abbas.
Hey, so, hi. My name is Aisha Abbas. I am a I'm a University of Exeter student on her placement year this year. So I'm currently at the ICH for the Institute of Sports and Exercise Science. Just a few fun facts about me. I really like baking, specifically cinnamon rolls, and my favorite Sanrio character is Cinnamon Roll. I like crocheting, I like Hamilton and other musicals, and I like gacha games, so I tend to gamble. Jokingly, of course. So I, this year for my placement year, have been working with the Active Mind study. So I'll quickly run you through how that study kind of goes, and then I'll talk about my hypothesis, And yeah, so if you looked at the picture to the left, you will see that we have a big study design that looks confusing, but I'll explain it perfectly. So the active mind study looks to, what's the correct word? Investigate different various lifestyle factors and the effect exercise has on them. So when first joining the study, participants are asked to take an intake questionnaire, which has a personality quiz. One of the big traits that I look at is neuroticism, which the best way for me to describe that to you is people who are highly neurotic tend to easily display more negative emotions, such like stress, worry, things along that genre. So once after taking the intake questionnaire, these people are split into two groups, a control group and an intervention group. So our control group lives their life completely normally throughout the entire study, while our intervention group from week 2 to 7 does exercise, of course. They do exercise 4 times a week within 2 hours of waking up, which reaches 70% of their max heart rate. We also ask them during week 1 and 8 to complete daily evening questionnaires, and the reason we ask them to do them in the evening is so we can just get their overall stress for the day. So my main focus was looking at if neuroticism mediates the effect of exercise, the exercise intervention on stress, which essentially kind of means if I split people into a high neuroticism group and a lower neuroticism group, what does the exercise intervention do to them? So people with high neuroticism typically will be more stressed. So I'm assuming that the exercise intervention will actually lead to a greater reduction of stress compared to those who are in the lower neuroticism group. So to analyze this, I collected all the data and from week 1 and week 8, and then averaged their weekly stress scores. Once those were averaged, I created an ANOVA to compare the control and the intervention. Now, there was no overall effect when it came to the ANOVA, despite there being a slight trend where in the control group there is an increase in stress, while in the intervention group there's a slight decrease in stress. It was not significant. However, if we look to the picture to the right, when we're looking at change in stress, really sorry, I didn't realize I covered the negative 20. So it's 20, 0, and then negative 20. But you can see as neuroticism increases, for the control group, there is a larger increase in stress. And then for the intervention, as neuroticism increases, there's a greater decrease in stress, which was significant. So essentially, it's implying that an exercise intervention might actually be more beneficial for people who have high neuroticism compared to those who have low neuroticism, even though exercise overall does not decrease stress. And yeah, that's all I have. Any questions so far? Yes.
Did you normalise for what people do for a living? Because one might argue that neuroticism, or rather stress and anxiety, can be positive factors in a person's life.
Yeah, our main sample was usually UCL students and staff. So just to keep that, they would be typically in the same stress level. Especially, you can see as week 1 and week 8, it was beginning was no exams, everything was kind of chill. Week 8 there was, so we did expect some stress from the start, some stress from the sample because they have kind of a structure within this 8-week period, if that helps. Yeah.
There was another question in the back.
So, thanks, nice talk. I was wondering how you assess the level of neuroticism in the subjects in the study. Did they undergo a neuropsychological evaluation?
So inside our intake questionnaire, we included the Big 5 inventory test. It's like the MBTI personality quiz. I believe that we had 10 items in, and it was questions of typically I would feel more relaxed, or I would feel more close to people. And using that, we then created a code that would then analyze that and then create a neuroticism score based on that, from the score being from 1 to 10.
Okay, I think we have one very last quick question.
Quick one. How did you select the
It was randomized, yes. Okay, sorry.
Thank you very much. So we'll move on to the next speaker, Tracy Xia.
Okay. So, hello, everyone. Good morning. My name is Tracy, and I'm a third-year medical student intercalating in oncology. And today, I'll be talking about my project on investigating biological pathways of low-intensity pulsed ultrasound treated 3D biomimetic models of triple-negative breast cancer via RNA sequencing. So, who am I, and why breast cancer? So during my work experience at Endomag, helped me gain an insight into oncology and the intersection between medicine and engineering. The technology uses a probe to detect magnetic markers localized within the tumor to allow for precisional resection. And watching the surgery through VR headsets was absolutely fascinating to see here in the middle. And aside from this, to maintain a good work-life balance, I love playing badminton. I'm part of the RUMS badminton team. And I was born in New Zealand, which is a beautiful country, and if anyone wants to visit, feel free to connect. Yeah, and now onto my project. So after a patient receives a diagnosis of triple-negative breast cancer, their first concern is usually their life expectancy or quality of life. And this is frequently determined by the efficacy and toxicity of the treatment. However, for triple-negative breast cancer, it lacks 3 hormonal receptors, meaning that targeted hormonal therapy is not possible against this subtype, leading to more systemic, such as chemotherapy. However, this is highly toxic. Alongside this, it is a highly heterogeneous disease, meaning that it's diverse, having different molecular, genetic, and phenotypic features, increasing its risk of therapeutic resistance. And LIPUS has demonstrated the potential, I'll refer to low-intensity pulse ultrasound as LIPUS, the potential to act as a non-invasive modality through mechanotransduction to help tackle these problems. So in my project, we used 3D triple-negative breast cancer tumoroid to recapitulate the in vivo environment, as well as LIPUS at intensities above diagnostic and below thermal thresholds, and lastly, using RNA sequencing to identify transcriptomic level changes. Now onto the methodology. So to understand RNA sequencing, we need to understand the central dogma of molecular biology. And gene expression begins during transcription when RNA polymerase unwinds the DNA and uses one section of the DNA and uses one strand to act as a template strand to synthesize the complementary mRNA. This then undergoes translation to form a protein in the ribosome. And so RNA sequencing data analysis aligns this mRNA molecule with the human genome to identify genes differentially expressed. And now onto the results. So to identify whether 3D models better recapitulate the in vivo environment compared to 2D, I compared 2 3D models being the synthetic polyethyl glycol and the dense collagen scaffold against the 2D monolayer. I identified a downregulation of oxidative phosphorylation and proliferation, which suggests a more restrictive environment and more representative of the tumor microenvironment in vivo, as well as that 35% of the differentially expressed genes were due to this dimensional difference. And onto the second part of my results, I identified a pathway in which lipus acts out through its gene expression of upregulating mechanotransduction sensors to increase and upregulate 3 pathways leading to a more invasive phenotype, upregulating epithelial to mesenchymal transition. So overall, this shows the value of 3D biomimetic models to understand transcriptomic bioeffects, and it allows a wider understanding and exploration of wider parameters of ultrasound, and yeah, provides the opportunity to understand their associated bioeffects. Thank you for listening.
Any questions? Can I ask you what would be the clinical repercussions of your findings? How would this translate into clinical practice?
Yes, it's a really good question. So to translate this to clinical practice, we need to do further experiments, because here is mRNA expression, but it doesn't actually mean that the protein will be expressed. So further targeted proteomics experiments would be required to identify whether this pathway is actually involved after lipus, like intensity ultrasound, is provided. So after that, we can find, because here it's like pro-inflammatory effects, so in the future, this pro-inflammatory effect may be used to allow for the tumor to be more hot, which means more immune infiltration, to allow for it to be detectable for immune therapies and things like that. So once these like pathways have been verified, that can be more like lipase can act as a more complementary therapy. Yeah.
Thank you very much. So we'll move on to the next speaker, Alisa Ivanov. And if I could ask the next speakers to possibly sit down here so that we are running a little bit late and they could speed up the process. Thank you. Just press here. Let's load. Okay.
Great. So my name's Elisa Ivanov, and equally I'm a third-year medical student intercalating in surgical sciences. Really quickly about me. Right now I'm really interested in general surgery, and that's kind of a premise of why I'm interested in the project that I talked about. And outside of studying, I've been very much involved in SALSA, I've been on the volunteering team for SALSA, very much a part of my kind of uni life. And I'm very proudly Moldovan and Romanian, kind of a core part of who I am. To talk about the kind of actual my project, so pancreatic cancer. Why? So it's one of the 6 leading causes of cancer mortality, and it has a kind of dismal post 5-year survival rate of kind of less than 8%. Reasons for it, 3 main ones. So the late detection due to non-specific symptoms, treatment resistance due to desmoplastic stroma around it, and then also the high metastatic potential. And that's exactly what my project kind of focuses on, this kind of high metastatic potential. So where does it metastasize? Mainly, primary site is the liver, and in 70% of cases, pancreatic cancer goes to the liver, with loads of different reasons, which I'm not going to talk about, but because of the pancreatic environment itself, and also because of the environment that the liver itself kind of provides, and yeah. And what we want to talk about is also what the liver is, if it's secreting anything to make the pancreatic cancer cells metastasize to the liver more and become more metastatic. So that's exactly what my project was looking the effect of the liver secretome on the metastatic potential of pancreatic cancer cells. What we did was a basic kind of 2D mono culture. So we took stellate cells and secretome from them, and then we cultured pancreatic cell lines, so BXPC3s, and then we did some 4 basic assays. So we looked at imaging, we measured metabolic activity, cell counting, and then we looked at qPCR to measure kind of the mRNA expression of genes. And what we saw, if we look at the pink here, we saw an increase in metabolic activity of the pancreatic cancer cells when they were exposed to this liver medium. But interestingly, whilst metabolic activity increased, the cell number itself didn't increase. And then if we look at the actual qPCR, so these are all markers of kind of epithelial to mesenchymal transition. And we saw a mix of some epithelial markers were upregulated, for example, CDH1, whereas some mesenchymal markers like vimentin and matrix metalloproteinases, which kind of facilitate the remodeling of the tumor stroma, were upregulated. So it's kind of a mix of this, and this kind of phenotype that kind of leads us to think of a hybrid epithelial to mesenchymal transition, which makes can make pancreatic cells more metastatic, and that's really our main kind of results. The impact of it is mainly, well, if we can see that there's things from the secretome that are making a pancreatic cells more metastatic, then maybe that could serve as biomarkers to help see if to help kind of predict before pancreatic cancer metastasizes further, really. And importantly, this is very much basic level. It's kind of on a 2D cell, so it's very far from being actually translational understanding. That's why we want to do a lot of future work, kind of to see a co-culture, to see the actual signaling between the cells and the pancreatic cells, and then also look at 3D modeling to see the more of the environment and how the tumor environment affects it. And that's all I really wanted to talk about, and I'm happy to have any questions.
Question in the back.
So you mentioned that metabolic activity increased while the cell number actually did not. So what do you think this metabolic activity represents?
Well, it's because of the, we're hypothesizing that the liver secretome has additional growth factors and additional factors, which is providing kind of extra nutrients to make the cell more metastatic, really. So that's why we're hypothesizing the increase in metabolic activity.
One more question?
Again, I know you said this is really early stages, but in terms of clinical practice, from what you've said, if I understood this correctly, you're sort of able to see when the cells are about to metastasize. So does this rely on catching a cancer early for this to have clinical tie-on, or do you think this would still have a use if a pancreatic cancer is called when it typically is, which is later on?
I mean, this is very far from clinical. This is more so understanding the mechanism of if the liver is even making pancreatic cells more metastatic. So the clinical is, this isn't that translational, but I guess it would be more earlier stages to see if we can try before it becomes more metastatic to the liver.
Okay, thank you very much. So I'll call to the stage the next speaker, Elizabeth Awuzoda. Oh, sorry. There you go. Yes. Do you want to present him out? I think.
That's fine. Yeah, we can do them all. Good morning, everyone. My name's Elizabeth Awuzoda, and I'm a third-year medical innovation and enterprise student working with the HEVI lab group under the supervision of my amazing supervisors. So who am I? So outside of this, I actually work in InsurTech as a forward deployed engineer, but I am a medtech enthusiast, and I'm very interested in closing the gap in terms of translational research and using technology to do that. And when I'm not in the lab or at a laptop working, I'm actually obsessed with cake decorating, which all these fields actually similarly require the same amount of level of detail, so that kind of links them. So my project is actually about proliferation dynamics in cultured ex vivo prostate explants. A bit of a mouthful, but why this is important is in prostate cancer, there's this issue where when patients are treated with radiotherapy, about 15 to 30% of the men who are treated with this have radio-recurrent prostate cancer where it comes back. So it's quite a significant group of people where we don't quite understand why they are not responsive to that therapy the first time around. And so my goal of this project is to essentially see, are there better ways we can model prostate cancer and overcome the challenges that we currently see there? And so one of the main modeling challenges here is that prostate cancer is quite slow growing. It has very uneven proliferation, and it's also limited by hormonal signals, which makes it very challenging to develop models. And we actually need these models to recapitulate tumor biology quite accurately to ensure that we can use these models to predict patient responses to drugs and potentially avoid overtreatment, hopefully closing that translational research gap. And so why did we go with explants? So 2D cell lines, while they're very high throughput and quite easy to access, they don't accurately capture that tumor morphology, different aspects like heterogeneity, and they're not as translationally relevant. So we went with explants for that reason. So my workflow involved, prior to this, my supervisors actually did cultures with varying conditions, so differences in cell, like serum, scaffold types, and then those were turned into FFP TMA slides. So I actually did multiplex immunofluorescence on these, using the markers DAPI to identify the nuclei, Ki67, which helps us see where active proliferating cells are, as well as EpCAM, which shows the epithelial borders. So yeah, as well as H&E staining, and we imaged them and then did analysis on them to hopefully identify how well these cultured tissues progress over time and how well they capture that tumor morphology. So in terms of my results, they're still preliminary at this stage, but here's an example of one of the immunofluorescent images, which we're able to separate each marker and hopefully capture exactly where the cell is proliferating, which will help us tell whether it accurately reflects how prostate cancer cells grows. We also did some H&E staining to look at the quality of tissue. And what we did find at an early stage is that as you go down the image, here we're comparing FPS, fetal bovine serum, against HPL, human plasma lysate. And as you see, as time goes down, you kind of see a decline in the structure of tissue, in particular that glandular structure and epithelial borders, which is what we would expect to see. But at that early stage, we did see that FPS had a slightly better tissue structure, which will kind of influence the project later on. So overall, it's been a very exciting project so far, and hopefully this will contribute to some real translational research and trying to see how drugs actually behave in these models. So thank you.
Thank you.
Any questions?
I was going to ask, so as you know, prostate cancer is a very heterogeneous cancer. So are all of these explants taken from cancer cells within the prostate or from metastatic foci?
Yeah, these were directly taken from the prostate. Yeah.
Okay, thank you very much.
Thank you so much.
Okay, I think now is the next speaker, Elizabeth Fu. Perfect.
Okay, so good morning, everyone. My name is Lizzie Fu, and I'm a medical student intercalating in surgical sciences. And today I'll be presenting on the management of sternal mediastinitis in heart and lung transplant patients, which is a rare but life-threatening complication and poses unique reconstructive challenges. So a little bit about me. I'm interested in pursuing a career in plastic and reconstructive surgery, which stems from something personal. I was born with microtian oral atresia, so I have an underdeveloped external ear, which you can see on this left photo. And I've experienced reconstructive surgery firsthand. But outside of medicine, I enjoy lots of hobbies, including sewing kasut manik, which is a traditional hand-beaded shoe. And you can see that on the right. So on to the project. After a heart or lung transplant, a small number of patients can develop a severe infection of the breastbone and the space around the heart, which is called sternal mediastinitis. And to define it properly, it is the most severe form of deep sternal wound infection, which involves the sternal bone itself with purulent drainage. And this can be diagnosed when an organism is isolated from mediastinal tissue that can be identified intraoperatively, or when a patient has chest pain, sternal instability, or fever, alongside purulent drainage of a positive culture. So it's pretty rare, but it can be fatal, and published mortality rates reach up to 40% in transplant-specific patients, which is significantly higher than the 10 to 25% that's reported in general chest surgery patients. So why is this harder in transplant patients specifically? First, there's two main reasons, but first, lifelong immunosuppression impairs wound healing, and this leaves patients vulnerable to unusual infections like fungi or resistant bacteria, which is far more complex than the typical staphylococcus in general cardiac patients. And secondly, the surgery alters the anatomy as well. So for example, with lung transplant patients, they have a clamshell incision, usually, which can cut the key blood vessels in the chest wall and rule out standard flap techniques that you might use if you need to do reconstruction. So you can see in this photo here how a clamshell wound was managed with reverse abdominoplasty, which I will explain and expand on shortly. And so the aim of this project was therefore to review 8 years of cases from a single surgeon and evaluate whether our reconstructive algorithm holds up in this high-risk population. So this was a retrospective case series of all heart and lung transplant patients managed for this complication, which was at Harefield Hospital, between 2017 and 2025, and it was conducted alongside a PRISMA-compliant systematic review. Reconstruction was tailored to the type of transplant incision, which is following our locally devised algorithm, which you can see on the left. So all 10 patients, which are in the table, there were 10 patients. Of them, 7 were lung transplant patients who had a clamshell incision. 6 of these lung transplant patients were reconstructed with reverse abdominoplasty, and 1 was with a split thickness skin graft, which was because it was not as deep as the ones who needed a reverse abdominoplasty. Of the 3 heart transplant patients with a median sternotomy, 2 had a bilateral pectoralis major advancement flap, and 1 required a latissimus dorsi flap from the behind due to the compromised local tissue in their pectoralis, which came from prolonged ventricular assisted device support. So the results show that 10 out of the 524 transplant patients at Harefield developed this complication, an incidence of 1.9%, higher, which is higher than the 0.1 to 1.4% in general cardiac surgery. And all 10 were successfully discharged with no recurrent infection within our 6-month follow-up. And our algorithm proved applicable across the full cohort despite significant variation in incision type, microbiology, and patient complexity. So the systematic review also supported this approach. It identified the pectoralis major flaps as the most common reconstruction in the literature and advocated early muscle flap coverage over conservative debridement alone, which frequently failed and required flap salvage. Mental flaps were reserved for extensive dead space. So to conclude, sternal mediastinitis following heart and lung transplantation is rare, but it carries significant morbidity and mortality. Addressing it requires recognizing the unique vulnerability of this patient group and applying aggressive multidisciplinary support and source control, following a structured reconstructive framework adapted to the anatomical constraints of each transplant. Thank you very much.
Got a question?
So during the 6-month follow-up, some of the questions that were asked were about how they were doing psychosocially. Specifically, I think most of them from the data were just very happy that they were still alive, which I think was the main outcome that they were concerned about. And so there was one patient who did struggle psychosocially. Unfortunately, one limitation of this study is that we only went up to 6 months, so we don't know much more after that. But he did get some treatment for that as well.
One more question?
So we did not find any link with BMI. The differences in age was actually because several of the patients had cystic fibrosis, and so that might have been a reason why they then needed a lung transplant. It wasn't so much about any other comorbidities. A lot of them had to do with congenital issues. Yeah,
One last question.
How early?
How early after the transplantation did the infection occur?
That was very variable. I did not have enough space to put it on this PowerPoint. Some came back several years, like within 1 to 2 years, came back with an infection, and some were in the following days. So it was a huge range, and that's something we are going to discuss. We discuss in the paper. Yeah, yeah, it is worth looking at. Thank you.
All right. Thank you very much. And I'd like to welcome to the stage the last speaker of this session, Ashrika Padiyar.
Good morning, everyone. My name is Ashrika Padiyar. I'm a third-year medical student at UCL, and I'm intercalating in surgical sciences as well. And I'm excited to show you my IBSE research project. So my introduction is very brief. I am a UCL student ambassador, and I also get involved with basically everything UCL, society, sports. But outside of this, I bake, I make travel vlogs with my sister on YouTube, and just like to de-stress from medicine with activities like yoga. So the inspiration for this project was I was shadowing in lymphedema clinics, and I noticed that routine monitoring processes for lower leg lymphedema were particularly difficult for patients. And I thought, is there a faster tool than the current standard? So lower leg lymphedema is swelling of the lower legs. It is a mobility limiting and painful condition for patients, and the current standard of limb circumferences requires 4 centimeter intervals from the medial malleolus up, resulting in around 10 measurements per limb. The entire procedure can take from 10 minutes to 90 minutes, depending on how many comorbidities the patient's leg has. So tissue dielectric constant proposes an alternative. Tissue dielectric constant represents local tissue water content and could be a potential for a replacement in this monitoring technique. Our proposed design was to take 4 points, shown here, A to D, and each of those measurements only takes 10 seconds. Clinically, of course, if this was validated, it would mean that it could be rolled out nationally and there would be faster appointments with patients. So my method was that it's a prospective cohort study done in 2 clinics in Sussex, and 21 patients were included for primary analysis. Before I used TDC as a mean to monitor, we had to ensure that the 4 points A to D behaved consistently. So alongside other tests, we did a 2 ways repeated measure ANOVA, which had non-significant findings. So then we could be able to use the TDC mean. And the interesting bit is that when we compared change in TDC mean compared to total limb volume, which were derived from the limb circumferences, they had a 1-to-1 relationship. And this is novel in literature because most of the studies that use TDC as a monitoring tool only show them in a trial setting, so not in routine patient care. But in our case, we had a mixed presentation type, we had a mixed treatment type, and this 1-to-1 relationship still remained. So yeah, that's my talk. And the key take-homes are that the 4-point mean is justified. TDC change correlates with limb volume change, total limb volume change, and potentially, if validated by a larger study, would mean that we have faster appointments for patients and more comfortable appointments for patients. Thank you. I'm open to any questions.
Thank you very much. Any last questions for this session? Yeah, there at the back.
No, so interclinician reliability was not assessed. It's actually a gap in TDC, or tissue dielectric constant literature, but it's planned for a larger study. But no, every patient was... The patients were seen by the same assessors, but it was just based on routine clinical scheduling.
All right. One more question.
The cohort of patients, were they primary lymphedema, secondary lymphedema, was a mix of both?
No, it was generally secondary lymphedema. I think primary lymphedema is relatively rare compared to secondary lymphedema anyway. But yeah, the entire cohort just happened to be having secondary lymphedema.
Did you take any comorbidities into account when you did your
No, we didn't look at they were included if they had lymphedema, but they could also be included if they had lymphovenous lymphedema. But the cohort was so small that I think only around 2 patients had lymphovenous issues as well. So I think looking at the data might have extrapolated any findings. But I would like to do that in larger studies, yeah.
We'll have one last question.
Is this just a comment really? When you said about, somebody asked about same assessor,
Mm-hmm.
actually, the beauty is that anybody and everybody do it.
Yeah.
So in a trial, if you do that, that will be more realistic of what will happen in the real world.
Yeah.
So try not to standardize.
Yeah, which was the whole idea of the project, that I wanted it to reflect routine clinical scheduling and how busy lymphedema clinics can be. So yeah, thank you.
So thank you very much for all the speakers for the undergrad talk research, and I'm very happy to now welcome to the stage Professor Emberton, who's previous dean and eminent urologist.
Great. Well, lovely to be here, and great to see. I've already got some collaborative ideas. I need to speak to you afterwards about your work. Yeah. So I and we need help. We've got a kind of new clinical problem opportunity that we wish to research, and we don't know how to do it. And this is typical, right? So you see a bit of unmet need, you see a bit of opportunity, and then you scratch your heads to try and work out how best to investigate it, what questions to ask, how to address those questions, how to prioritize those questions, how to find the money to see if we can actually do it. So all these are real, and they're in real time. And what I want to do is just share the problem with you, and then see if you can help me with a way forward. And this hasn't been shared with many groups. Only one group, I think, two groups now. So a closed meeting in America, and I was visiting Professor at McGill the other day and chose this topic just to basically annoy them. So let's go through it. So I'll present the scene. It's a little bit long, and then maybe hopefully we'll have kind of 20 minutes of discussion. Can you remind me when we're halfway through? Have we got, what, 45 minutes for this? 45 minutes, yeah. Can you stop me halfway through, right? Because the important bit of this is the discussion. I thought this was going to be a bit more seminary, but we'll manage somehow. So, I'm a prostate cancer doctor. 5 years ago, everybody at risk underwent biopsy. Now, in 6 years, and maybe 6 to 7 million biopsies are done a year. At UCLH, we're not normal, but at UCLH, about half the eligible or men at risk have a biopsy. All right, so it's really interesting. And that's happened in 6 years. And so it's reasonable to ask, why it's happened, I'll tell you that. But it's also reasonable to ask why, whether this trend might continue, and whether we should be forcing this trend further by adding to the evidence base that we've currently got. But obviously a little bit of context. So we've been doing prostatectomy, removing the prostate now for about 120 years. This was the first prostatectomist, Hugh Hampton-Young from Johns Hopkins. And since then, we've been kind of removing the whole prostate when we see prostate cancer. So it's been a kind of, and that's been preceded by biopsy, but biopsy has changed. And obviously, during that time, we've tried to see if we could image the cancer, and that has really proved very unsuccessful until very recently. And this was ultrasound, and I think you can just about make out the prostate, but you wouldn't have a hope in hell of identifying any cancer within that very, very grainy appearance. And then something happened in the 80s. There was a very poor trial that showed that you could find more cancer if you spread your needles into the prostate using ultrasound as a guidance versus using your finger on the nodule and directing your needle onto it. All right? So there were 55 patients in this, grossly underpowered, an RCT. And this is one of the great papers that changed practice that was very, very, very poor methodologically. So this changed practice for 50 years, all right? One terrible randomized controlled trial. There are many other contenders for worst paper in the history of medicine, but this is probably one of them. And what they did was use the ultrasound to show where the prostate was, and basically you put your needles in there. And what they were finding was very low amounts of subclinical indolent disease, what we call insignificant prostate cancer, which was more prevalent numerically at the patient level than the nodules, some of which were benign, some of which were malignant. So the whole world shifted to these kind of random biopsies, which meant that everybody got a biopsy because there was no triage test between a man at risk, I've got symptoms, my PSA is high, I've got a relative with prostate cancer, my ethnic mix puts me at higher risk, all those things there. There's no test that we could say, well, what's your likelihood? The ultrasound here was used merely to place the needles. So the needles were inevitable. Hence, everybody got a biopsy. And then MRI came along, and many of you know the story of MRI, but obviously it wasn't fit for purpose until relatively recently, the last kind of 15 to 20 years, really. It clearly wasn't fit for purpose when it was first described then. And then our contribution, so we started, we were very lucky. A lot of science is about luck, being in the right place at the right time. We had early access to MRI. We had research active radiologists that wanted to work with us. And we did the first proper multi-center study evaluating MRI to see if we could see the cancer versus the standard of care, i.e. random biopsies, which I've just shown you, and a very exacting reference standard in which we biopsy the prostate every 5 millimeters. And that showed, it's not often that a new intervention treatment is twice as good as the practice standard, but MRI was, and that was a kind of massive, massive result. Although the paper, because it wasn't randomized and stuff, was quite difficult to interpret, so it didn't have a huge effect. But the standard of care for 50 years, based on that terrible paper, was worse than tossing a coin. So the sensitivity for clinically significant disease, as you can see, was 48. This was a very important study, didn't change practice because of the nature of the study, but allowed us to do a much braver study, which is randomized. And here we randomized men to the standard of care, you know what that is by now, versus a targeted biopsy if the MRI showed a lesion. So if you were randomized to the MRI group, you only got a biopsy if you had an abnormality in the prostate, which meant that fewer men were biopsied, fewer needle deployments, and yet we showed more clinically significant cancer, right? And that nailed it. Multi-center study published in the New England Journal of Medicine, and that resulted in guidelines changing almost overnight. And again, that's very rare in science. It normally takes a few years, for a paper to kind of get digested, and then for the guidelines to finally agree that they should change their documents. But NICE were very quick. April 2019, basically use MRI, blah, blah, blah. But the really important thing here was if the MRI was negative, this is the first document that said it, if the MRI was negative, consider withholding, avoiding, or deferring biopsies after lots of discussion with the patient. So it was qualified, but this was the first chink in the door that allowed us to have a non-biopsy protocol for individuals. And that's fascinating from a scientific perspective because it provides a control arm if you want to do research. And that had not been available to date. So there are today many biopsy reduction opportunities, and they largely come through imaging. First one you know about, and it's hardly it's hardly rocket science. So if you have a headache and your MRI of the brain is normal, nobody sticks a needle in your brain. If your mammogram is normal, nobody biopsies you with deference to the breast cancer experts. But it's kind of odd, isn't it, to biopsy something where your imaging test declares normal tissue. And then there are kind of indeterminate conditions. These details don't matter, but every test has a black and white, and every test has a gray zone. And the gray zones are also provide a very low yield if you decide to stick a needle in the prostate. So you can avoid a prostate biopsy if you've got a normal MRI, about 25, 30%. If you've got a gray zone, another 20% maybe. We're finding now, this is Australian research that was published very recently at the European Congress, if you've got an indeterminate MRI and your PSMA PET, so you bring in another triage, is negative, so if you've got an equivocal plus a negative, again, the yield is very low, so low as to not be worth doing a biopsy. And that's quite an expensive way to go about it. And of course, there are other things we can do. If you see an abnormality in any cancer, you don't have to stick a needle in it. You can use the diagnostic ability of watching a tumor over time. So you can ask the question, is it going to progress, or has it progressed over a period of time, and repeat the imaging. And we do that with lung cancer. If you have a small lung nodule, the general advice is to repeat the scan. If it stays stable, you leave it. If it grows, you treat it. And so there are other opportunities that we've got. But the big other thing that happened over the last 4 or 5 years is prior to radical prostatectomy. So these are patients now who have high-risk disease based on imaging, who say, I don't want a biopsy, I don't want tissue confirmation, I want to go straight to radical treatment without without you sticking a needle in my prostate. And it's very interesting. So this came from nowhere. The first study wasn't really a study. It was a collection of patients in which doctors and patients had colluded not to do a biopsy. It was a German study, very few patients, but 100% positive predictive value for clinically significant disease. So the imaging, in the form of positive MRI, positive PSMA PET, gave 100% likelihood at the patient level, not quite at the lesional level in this study, of there being clinically significant prostate cancer. And if that's the case, you'd have to ask, what's the utility of finding out or confirming something that's 100% likely? All you can do if you impose a triage test on a 100% probability is decrease that accuracy. And of course, other things can happen too. And then the Chinese took over. This is this year. This is not the latest study. There was a Mexican study last week showing exactly the same. The German study wasn't a trial. This is a formal protocol-driven, registered, single-arm study in which they identified men at risk. And again, they showed exactly the same. So all the men who were deemed to be at risk, who went to prostatectomy, remember, you get the tissue anyway, had clinically significant prostate cancer. And this has been repeated now 7 or 8 times. Not everyone is 100%. But the better studies are. So you can see the benefit here. 5, 6, 7 million biopsies done a year. The biggest block in the NHS waiting list for cancer waiting times is prostate biopsy. So you can, you avoid a false negative. You could miss the cancer, tell them they're clear, and delay the treatment. You could misclassify with a biopsy. You're obviously going to delay surgery. In some NHS hospitals, it takes 6 weeks to get the result of a biopsy to the patient. So you can see you have to wait for the biopsy, wait 6 weeks, and then go on the waiting list. We're talking about maybe 6 months delay in getting definitive treatment. It's cheaper, you avoid toxicity, and really interestingly, you have very clean surgical planes when you do the operation. Surgeons tend to advise patients to wait a few weeks after the biopsy so that the inflammation can settle down. I think that's more of a scheduling thing than a real thing, but it's advice that's almost ubiquitous everywhere else. And of course, there's no disruption of the anatomical compartments. These are high-risk patients, right? If you test positive for MRI, PSMA PET, you've got pretty bad disease. And I suppose the key question is whether by avoiding biopsies in this high-risk individuals, we could confer better oncological outcomes, not only by reducing the time to treatment, but actually by not disrupting the tumor, which we know to be high-grade and high volume by definition. And that's the kind of big question that we're asking at the moment. So can we take this further? You're seeing the door kind of being open, but the challenge will be in radiotherapy and maybe active surveillance and focal therapy where you don't have tissue. That's the kind of area of the research question. Could we do a straight-to prostatectomy study in the UK? None has yet been done. Do we have the equipoise to do that? What about really early cancers? Early detection finds cancers really, really early. This is a cancer. Our radiologists tell me this is 100% likely to be a cancer, but it's so small that actually sticking a needle is going to be futile. You could do it 20 times and miss it just because of the vagaries of tissue capture. Would these patients be better going straight to treatment, or should we be monitoring them because a biopsy is futile? So this is a new dilemma, which is the consequence of early detection or possibly interception. I'll skip that. So summarizing this bit, imaging is probably better than prostate biopsy in many cases because of its reliability. Poor reliability always confounds validity. Biopsy-free pathways are opening up. And we have, for the first time, the opportunity to study biopsy in all its dimensions because we can create a control. Possibly, right? And that's where I'm going to need your help. And now, how much longer have I got?
10 years time. 15.
Oh, fantastic. Yeah, I've been talking quickly. So the other element, the question that patients ask me maybe 4 times every clinic, and I'm sure it's the same in breast cancer, is will the biopsy spread my cancer? Or will the biopsy make my cancer worse? And doctors typically dismiss that as being a kind of bit mad. There's a lot of internet stuff on it. But mainly we dismiss it because we can't answer the question. It's not a scientific question that we've been able to address because we've had no control, because everybody needs a biopsy. Nobody will give you radiotherapy without a biopsy. Nobody will allow you to enter a trial without a biopsy, tissue confirmation. Your critical illness insurance will not kick in unless you have a biopsy. And so it's been an impossible thing to research. And this is a guy I was watching for a while and thought we should biopsy because he went into retention and was going to need his BPH removed. He's got 3 lesions. And he wanted to avoid a biopsy like most patients because they have this inherent belief, this kind of gestalt, that actually how could sticking a needle into a tumor be good for the tumor and the host? And this is a very strongly held view, but one that doctors have dismissed. People say good research is research that comes from questions that patients ask. This is certainly a question that patients ask. So let's see what happens when we biopsy this guy. You're going to see 2 needle deployments into the right apical lesion, but I want you to watch the veins, and the lower vein first, and there's an arrow pointing to the vein in case you're finding difficulty in finding it, and then the upper vein second. So let's play this. So that's the first needle deployment into the target, which is obviously MRI derived, but you can see the material in the vein all floating around after that biopsy. This biopsy is a high velocity injury causing cavitation and then regression of the tumor with huge pressures and then forcing tumor material out of the prostate into the venous plexus. And I think you've just seen the upper vein, which is quite a distant vein, but there's material in there. I think we don't know what material, but we can say that there are bubbles floating around the venous plexus as a result of our intervention. What those bubbles contain, we of course don't know. But there are several things we do to the tumor when we biopsy. We put a selective pressure on the cancer. We will definitely introduce cancer cells to other anatomical compartments. And there is some evidence that we introduce tumor material into the circulation in the form of circulating tumor cells. And there's a lot written on this, largely from the breast cancer literature, about what a high-velocity injury does to a tumor. So it changes it from a kind of epithelial to mesenchymal picture. In other words, the cells become a lot more mobile and leaky, which has pro-metastatic effects. This is one of many models out there. And this is just to remind you what we do. So all the energy on the tip of that needle, remember that the needle comes in very fast, causes the cavitation. The tissue then collapses into your cylinder, and then that's captured by the trocar. And there's a slight delay between the two. But you are creating a high-velocity injury, causing, this is obviously a simulation of a bullet, which you can see there, and then the collapse after that at enormous pressure. And then what you can't see here is the expelling of material from the entry wound, which in the prostate, in this gentleman, was at the apex and communicating the prostate to the outside, to the area outside the prostate, but also into the venous system. Now, does spread happen? It's rare. This is a prostate cancer from a transrectal biopsy. We don't do that anymore. Quite a recent publication. This is a prostate cancer in the perineum after a perineal biopsy. This is new. We have 3 of these on our books at the moment. And this was picked up by PSMA PET when the PSA was rising. Again, demonstrating that it can occur. And so the next scientific question is if it can occur, how common is it? Now, clearly, seeding into the skin is not common, but actually that may just be the tip of the iceberg. It may be that, that after biopsy, or a lot of the progression that we see after treatment, which is largely driven by PSA, is as a result of the biopsy or the actual trauma of surgical intervention, or both. And it might be, this is, theory, that you introduce cells to the surrounding area of the prostate and then operate, they remain viable, you then operate 4 to 5 weeks later, and the trauma and the metabolic response to injury is such that it allows those cells to embed further. So remember, there are two insults. Circulating tumor cells in prostate cancer have been reported. There's a kind of about a 14-fold increase in their presence after a biopsy, particularly if the biopsy was positive. And rather alarmingly, if you had circulating tumor cells after a biopsy detected, you were much more likely to progress after surgery. So your prostate's removed. Now, this doesn't mean you progress because of those cells, because those cells might be present as a result of a certain tumor type. But nevertheless, this has been reported. But interestingly, not reported on since. 6 years before this paper came out, and it doesn't get spoken about very much. Lots of evidence, again, from breast cancer showing that biopsies make a difference to the tissue. TGF-beta, CD4, CD8 all change as a result of a high-velocity injury. ECAD-herin changes as well when you compare the area around the biopsy to the area distant from the biopsy. So, in prostate, there's been almost no investigations of this type. How much post-treatment prostate cancer, how much of the post-treatment progression, I think I said this already, is due to the biopsy? We don't know, you see, because the first progression event is a rise in PSA. And what's interesting is that that occurs in people that were margin negative and organ confined. And moreover, if you irradiate the area where the prostate was removed, about 70% of them get better, demonstrating that the source of the rise in PSA was around the prostate. How did those cells that were organ confined and specimen confined get into that area? Is a legitimate question, I think. And of course, and after prostatectomy, about 20 to 40% of men progress. This is very high. This is a very, very high number, and a significant proportion of those are in men in whom you think progression should not have occurred. And I suppose the question is why. So, I finished. Yeah, so this is where we are. This is real. This is happening now. We are raising money to try and address many of these questions, many of which I haven't actually articulated yet. Interestingly, fundraising has been quite easy, patients like this, so we're going to be able to do it. The question is how we set about addressing the question, right? And that's where I'm going to need your help now. So I think I've got a couple of prompts. So obviously this is always helpful when addressing a clinical question. What's the population? What's the intervention? What's the control? And what's the outcome that we want to measure? And these are all really difficult questions that I want some help with. So with that, I'm going to, somebody's got a microphone, are they, that they're passing around? Yeah? Fantastic. I'm inviting criticism. This is a waste of time, don't do it. Equally, I'm looking for advice on what to do next. Clearly we have some ideas, but they're evolving, and so this will be really helpful. Thank you.
Thank you. I mean, certainly not a waste of time in my opinion, even as a non-clinician. The patients that I've been fortunate enough to meet have raised this for sure. So I agree that it really seems like it's a question patients are concerned about. Apologies for being a bit of a two-trick pony, but I think you need spatial transcriptomics.
I missed that last bit. It's quite hard to hear you.
Spatial transcriptomics, is this a term you're familiar with? Apologies for being a bit of a two-trick pony, is what I was saying, because that's kind of my answer to everything, and the next part is also my answer to everything. But I think that would allow you to look at the site of that insult from the biopsy needle and see, are you seeing increased immune response? Are you seeing wound healing issues? And you could even then look at distance to actually look at, are those tumour cells going from the lesion to the edge of the prostate, to the areas that you're suggesting they might travel. And the other thing that you could do with Elizabeth's models that you mentioned is that you could actually model this ex vivo to create a high velocity injury using something like a retractable needle into an explant as a sort of live perturbation, and see, does that induce the actual transcriptomic phenotypes that you've seen in the patients slightly less real time.
So I agree with you on both counts. So I heard Elizabeth's talk. I'm going to speak. This would be wonderful, to have explants, randomize them to high velocity injury versus not, and to explore the selective pressure that we are imposing. It is a selective pressure. It's quite a considerable selective pressure. But it'll be fascinating to see what happens. There is an intention of an immunological component. Obviously, we want to see if the process of creating a wound in a cancer changes the host immunity. That's obviously critical, and obviously we are working with Gert Attard on the fragmentomics of what it is that we're putting into the bloodstream after such an injury.
It's going to be absolutely beautiful. Thank you.
So thank you for that. Very helpful. Sir.
Thank you so much for the talk, but I just want to make sure that I understand the context of the issue. We were always told in med school that a malignant tumor is not waiting for a biopsy to spread.
A malignant tumor is not?
Waiting for a biopsy to spread. And a non-malignant tumor will pose no risk if we do a biopsy. Are we not sure about this anymore now?
No, I think this is uncharted territory. I really think we know. We haven't been able to research it. Yeah, and everything I've shown is anecdotal, and flawed. So I'm not, and actually, technology is such that it's allowing us to determine the prior probabilities of what's in the lung, brain, whatever. Presumably there will come a time when we can feature extract so much information from our imaging and maybe signatures from the blood that we will look back at a time when we used to stick needles into tumors in a very, very unreliable manner, because you're biopsying a different place every time, you're getting a different result every time. I think this is inevitable if you kind of play it out. I haven't even mentioned AI yet, but obviously that helps with the feature extraction. I mean, in a sense, with biopsy, you're feature extracting, aren't you? But in a rather old-fashioned way, you're obtaining some tissue from the organ, you're processing it, changing it hugely, killing it, and then you look at certain bits of it down a microscope, and then histopathologists disagree on what they find, and they have to go fly around the world to consensus meetings to set a set of criteria, and that's what we rely on. And remember, you can't repeat a biopsy, or you can, but it's not that useful. Whereas imaging, and I'm not saying that we've got the final product yet, or a combination of imaging, and I haven't given you the full talk, but there's lots of imaging coming down the line that's going to give us metabolic status of the tumor, and is going to give us, can recapitulate the underlying microstructure of the tumor that can add to the stuff we got. So I think this is inevitable. Unless the knowledge of the genetic mutations that are present are predictive of which treatment you have. And then you would be deliberately procuring tissue to inform a therapeutic decision. But I think biopsy for diagnosis is dead. It's just a matter of when. But I'm happy to be challenged on that. Yeah. So, the professor would like to speak.
Thank you. Just beautiful question. Well, the obvious randomized trial is to randomize patients to have direct surgery without biopsy and to have biopsy and have surgery.
So we want to do that.
So
right?
that's something is obvious.
That's planned.
But the data that you showed is
just on that. It's not straightforward, right? Because normally the story starts with a biopsy. Yeah. So the whole cascade of what you need. So where this goes back to population. If you are to randomize men who are destined for surgery, and of course you don't know who's destined for surgery usually until you've done a biopsy, so it requires quite a shift in thinking, and then you have to really think hard about the population that you are going to randomize. So it's not easy.
And you may
but we'll do it.
Yeah.
We will try to do it.
You could have an arm with observation in those groups as well, because we don't know what happens to that either, because we have not observed those patients.
Correct.
But the data that you showed is so similar to breast cancer, and you have alluded to it, is that you get a peak hazard of relapse after surgery, and that timing of relapse doesn't change according to the stage of the tumor. So 0 nodes versus 4 nodes, the peak hazard occurs at the same time, suggesting that surgery itself could cause harm. And there are now ways in which, and patients with metastatic disease, you find surgery worsens distant disease-free survival if you do surgery in metastatic disease. So that is not so well seen with early cancer because the impact is not so big.
Yeah.
So in prostate cancer, you could plot these hazard peaks and see if that changes, because surgery itself is going to be maybe harmful, and introduce things during surgery. In breast cancer, local anesthetic infiltration around a tumor has shown to improve survival, just that, or radiotherapy during surgery. And so there may be interventions to try and do the catch-22 problem. So there are 2 or 3 ways in which you can do it. And of course, do translational work to see what exactly is going wrong.
You're absolutely right. So there's one paper from breast cancer, I think from the Nordic countries last year. They identify this phenomenon in breast cancer of biopsy to treatment time. If your biopsy to treatment time increases, then your risk of mortality increases. And they postulate the biopsy as a mechanism for that. So if you leave it, over 52 days, then the tumors that you shed at biopsy or allow to proliferate or create this pro-proliferative environment have time to settle and establish, whereas if you operate or irradiate early, they don't. And they're suggesting kind of anti-inflammatories to try and stop this inflammatory cascade as a potential mechanism. And there's a huge drawing that they've got on how that might influence. And the other thing in breast cancer is that they used to do fine needle aspirates, and then they started doing high-velocity injuries. And there was an increase in mortality. I found one paper on this, you may know it. And they obviously it's before and after. And after, obviously, the tumors are smaller because there's more screening. So they adjust for tumor volume. They try to adjust for everything, and they still couldn't account for the increase in mortality as a result of a change in the way that the biopsy was done. So these are all slightly anecdotal. They're not perfect, but they do take your breath away when you stumble across these papers. So how are we going to investigate, Tom? You asked the question you want, obviously. The real issue here, one of it's societal and ethical. You've got to have histological confirmation before you can be recruited into a clinical study. How are we going to change that? How are we going to change all the kind of insurance stuff? So there are kind of societal aspects to this, and medico-legal, which are very relevant. Currently, radiotherapists won't treat without a histological confirmation for some reason. Are there any radiotherapists here? No. How are we doing for time? You'll stop me.
Yeah, I'll stop you. Got another 10 minutes.
Tom.
So, Mark, as you know, I'm not an expert in cancer at all. This is a fascinating problem, really interesting research question, so thanks for bringing it up. I just wanted to slightly challenge you on statistics. So it always worries me when somebody says something is 100% likely to happen or to be inevitable, especially when we're looking at really small things through MRI. And I'm just wondering whether you really mean 100% likely or whether there's a bit of wiggle room on that.
Well, I mean, we've got 8 papers now, all right? The majority from China. I think they can count. You know, I think what we're doing, we're identifying, you know, I think it's actually an easier task than perhaps I've portrayed. If you test positive for MRI, PSMA, PET, and some of them have used something called PSA density as well as a third thing, what you're doing is qualifying people with very high burden, pretty advanced disease, right? So these are 3 qualifications, and if you get to that, in 6 of the 8 studies, it's 100%. If you saw the first paper from Germany, it's 100% at the patient level. They had 24 patients and 54 lesions, and they were 96% at the lesional level. So a patient could have 3 or 4 lesions, and if they declared the lesion abnormal, they were right 98% of the time. So obviously we're going to get it wrong occasionally. So I agree there's no such thing in the world as 100%. But we get it wrong frequently with a biopsy, right? So I showed you the sensitivity for clinically significant disease of the standard of care biopsy. It's 48%, you know?
That's really shocking. Yeah.
It's 48%. So, you know, you are telling people they're clear when they're not. And maybe that's the worst error. You know, you're delaying treatment, telling people they don't have cancer when they have. And so doing nothing is not without error. Yeah, I think, yeah. But I think it's reasonable. Obviously, it's amazing to watch Chinese researchers now. They can really move much more quickly than we can. And in fact, I haven't told you this, they've got a registered randomized trial, registered last year. I don't know if they're recruiting yet, but China have registered an RCT of a biopsy, non-biopsy approach. But obviously, we would like to see if we could do it in our own jurisdiction.
Yeah, I think it'd be really interesting to do. And I think, obviously, informed consent is really important in this sort of procedure. Yeah. And as part of that, I think we need to be really clear when we are informing the patients, giving them that information so that they are really making an informed
So obviously, there's a big PPIE, so patient and public involvement in this. That's actually quite easy. A lot of them feel quite strongly. A lot of people remember their biopsies being the worst event that ever happened to them. So that's quite good. The challenge is the professional agreement, getting consensus. So there's some Delphi work planned. You know, can we get everybody in a room and to agree? And importantly, find the areas where there's disagreement, because they are the areas in which we want to research. You know, so that's all happening. I think our kind of medico-legal, societal thing, we just haven't got a plan for yet. And that might be the hardest.
Sorry. You have several thousand patients already treated.
Yep.
So they would have had all these imaging techniques done
Yes.
before.
Yes.
Retrospectively, if you analyze all their imaging techniques as a denominator, and then say these are the ones I would have gone direct to surgery, and you see if that reaches 100%, then you have got a parameter.
Yes, no, you could do that. Yeah,
That would be a big study.
Yeah.
And
no,
that might validate in terms of medical legal
could do
aspects,
that.
saying that, well, these are the parameters we decided. I mean...
Yeah, no, that's a good student project for somebody. Yes. Because the data's there. Yeah.
I think your task is daunting at best. But I wondered, you talked right at the very start about people who are predisposed, and then that sat there and I listened to the rest. I wonder, when you're thinking about your population, are you going to treat, if you put these patients into 2 cohorts, are you going to take into account those with genetic, ethnic background or otherwise predispositions and treat them or consider them within those 2 groups differently?
Really good question. So that's a population kind of question. So who is it that we would offer randomization to? I mean, at the moment in prostate cancer, the tissue doesn't influence, you know, the decision making, but that's not to say that it might not in the future. And part of the consent would have to tell the patients, if we don't have tissue in the bank, we won't be able to go back and analyze it if we find that a certain gene subtype responds to a certain new drug, right? So they forfeit that opportunity. That would have to be in the consent, I think. But we haven't thought about high risk. The high risk groups are rare. So the BRCA2 is the obvious one. Family history is not a big risk factor. The cultural and ethnic, I mean, black men have been in the news yesterday. In fact, the Department of Health are addressing that today. I was meant to be there, but I'm not going. I think it's difficult. I think it's difficult. I would, you want to try and get the population, ideally, in research terms, as representative of the group that you are eventually going to treat as possible, and therefore resist requests to limit it. But some of those requests to limit your population will be very legitimate. And I think if there are safety concerns about high-risk individuals, we'll have to listen to those. So I don't have a straight answer for that. But we've not discussed that yet, so that's a new question, which is really helpful. Thank you. They might, because they won't have their biopsy, their tumor missed. Yeah. And also behind this is a very kind of interesting conceptual change. And this is maybe the hardest and the most interesting, is that we think of cancer down a microscope because we always have. It might be possible in the future to think of cancer as exhibiting gene expression through different means. And that one of those means might be imaging, circulating tumor fragments. It can, so in other words, we can define the entity differently in the future, but that's a really hard thing to do when we've been doing it histologically now for so long. And remember, the histology is quite a downstream, fairly fixed expression of what the cancer is. It's gene expression, it's kind of proteins, it's microenvironment, it's host immune effects. So, but it's fixed, yeah. Whereas imaging is a bit more dynamic, and might have more dimensionality now. Time to stop.
Another 5 minutes, if you can.
I've had enough.
Okay.
Any other questions? Yeah.
This might be radically oversimplifying it, but ever since you mentioned earlier the example of the bullet and the low pressure and the potential launch of whatever's being launched into a patient's bloodstream, sort of going along the lines of what was said earlier with being able to model this, if you were to suspend a prostate that has been taken out, or suspend what she's been talking about in a solution and then cause said injury, would you not be able to spin down and find out what you've added to your solution? And then you'd be able to find out if you're causing air bubbles, if you're launching cells, and if that could then actually be what is causing what we heard earlier, which is the measurable spike at always the similar time post-procedure.
I think it's a great suggestion, and actually I think to do this type of work in parallel, because you get the results quicker. The trial's going to take years, and actually to kind of help inform, encourage debate, allow people to change their minds. People take quite a long time to change their minds, and just having prompts and bits of evidence which are imperfect, a suspended prostate doesn't have a blood supply, et cetera, et cetera. There's no immune system, but there might be elements that you can derive. Does the entry wound, or does the collapse and the entry wound result in tumor material going into your saline solution? Is a really another student project, yeah, which is a fantastic kind of question to ask. And hopefully it's either yes or no. But ultimately, they have to be, we have to do this in human beings. And actually the technology now, so the other enabler, one is we've got a control, which is probably the most important, but the other is the technologies now to look at circulating tumor fragments, circulating tumor cells, are much better than in 2020. That was pretty impressive, 2020, a 14-fold increase after biopsy, Yeah. Well, thank you. It's time for lunch, is it?
Yes.
Fantastic. Thank you all. Thanks for your ideas. Yeah.
Yeah. Before we fully start session 2, I'd just like to invite Joanna, who is an MSci student, to the stage to introduce her presentation.
Okay, good afternoon. I hope you had a good break. So I'm Joanna, and I've just finished my degree in medical sciences and engineering. So I'm from London, and some people have said that's a little bit boring, but I would disagree, especially when you've got some of the best musicals on your front door. And when I'm not at the theatre, I like to do anything creative, like knitting and crochet. And then the picture at the top is from last year, where I won an inclusive design competition, where my friends and I designed an inclusive and accessible TV remote. So this year I've been working on optimizing high-intensity focused ultrasound for the treatment of endometriosis. So endometriosis affects 1 in 10 women, and it's characterized by the growth of the lining of the uterus growing outside of the uterus, and lesions can be found anywhere in the body. It's more commonly found on the peritoneal surface, which is the abdominal lining, followed by the ovaries, which is associated with infertility, and finally 20% of patients will have lesions on their deep pelvic organs, and that's associated with painful bowel movements, painful urination, and pain during or after sex. So 90% of patients will have some form of chronic pain, and patients have a 19% reduction in quality of life. Currently, there's no cure for the disease. You can have pharmaceutical options, which include contraception to reduce estrogen levels in the body. However, that has negative side effects, and obviously you can't use contraception forever. Surgery to remove the lesions is quite high risk, as you risk damaging any nearby organs. So overall, this obviously has huge healthcare costs. Obviously, surgery is the most expensive, and patients are also less likely to be in work due to their symptoms, which obviously affects their personal finances, and it costs the US economy about $78 to $119 billion a year. So studies have been looking at high-intensity focused ultrasound as an alternative. So that's quite similar to diagnostic ultrasound, except you're using a higher-powered beam, and that is focused onto the lesion to heat it above 55 degrees, and that will cause necrosis of the lesion. Studies have shown that this significantly improves symptoms, and it's much safer than surgery. However, the lack of optimization means that there's some inconsistencies between studies, so it can't be translated to the clinic yet. So that's what my project aimed to do, but we're going to use a computer model. And it was hypothesized that by overcoming any bowel aberrations, you can increase the acoustic dose and temperature on the lesions, and you'd also be able to reduce the acoustic dose and temperature on any surrounding organs. So I had to get some open source MRI images and segment that into a 3D model. I fed that into an acoustic simulator to assess the effect of the HIFU beam, and that was based on the properties of a HIFU transducer. The optimization process itself used time-reversed acoustics, where you have a point source at your desired target, emit ultrasound waves towards your HIFU transducer. The pressures on the transducer are then converted to velocities, and they're reversed in time and then emitted by the transducer itself. So then you recreate the same ultrasound propagation, and that way you're able to focus your beam onto your desired target. So you've got the results on the right, and you've got the temperature results specifically for an ovarian lesion at the top and a deep pelvic lesion at the bottom. So you can see that focusing has been improved considerably as the distribution of heat spots has been greatly reduced. The hypothesis for having higher temperatures and dose at the lesion was rejected, as that unfortunately didn't happen. But the hypothesis for lower dose and temperatures on any surrounding organs was accepted. But as you can see, there's still some high temperatures on the bones. So further optimization of the HIFI transducer itself is needed to ensure that the bone remains safe of heat damage. Thank you.
Any questions?
Thank you for the presentation. In terms of clinical applicability, which lesion would you be able to target? What localization of the lesion, and how would you be able to reach them with HIFU? Because obviously there's a limited distance between the transducer and your target area that you can have.
Okay. So just remind me of the first bit quickly.
The localization of the lesions that you could target and how to reach them.
Okay, so currently in the clinic there's two modes to do so. You can do so transrectally. However, that's obviously quite invasive and has some side effects associated with that, or you can do it transabdominally. By altering the frequency of the transducer itself, you can actually change how deep the beam will go. So you can access the lesions. There's no particular lesion that you won't be able to access at the minute. The studies haven't been looking at ovarian lesions, and I think that's probably because the properties are to do with blood, and that's obviously quite a high heat absorber, so it's quite high risk. But I can't see any reason why you can't access a particular lesion, because you can target them easily.
Okay, thank you.
Thank you.
I'd just like to invite our next speaker to the stage, Aoife Brady.
So now to discuss my research project. The title is The Effect of Glucagon-like Peptide 1 Receptor Agonist. So now to discuss my research project. The title is The Effect of Glucagon-like Peptide 1 Receptor Agonist on Perioperative Outcomes in Hip and Knee Arthroplasty, a Systematic Review and Meta-Analysis. Hello, my name is Aoife Brady and I am going to present my dissertation that I completed as part of my Master's in Perioperative Medicine. Thank you very much for giving me the opportunity to present my research. I apologise that I'm not able to attend in person. Now for our methods. Due to clinical we included studies that compared adults undergoing primary hip or knee arthroplasty with and without GLP-1 receptor agonist use. We searched 7 electronic databases. We used the Covidence Systematic Review tool for data extraction. We used Review Manager to conduct a meta-analysis. We used the grade classification system to assess the certainty of evidence. 2 independent reviewers were used throughout the process, and a 3rd reviewer was consulted to resolve any discrepancies. Now for our results. We included a total of 6 retrospective cohort database studies which included over 48,000 hip or knee arthroplasty patients. We found a statistically significant reduced risk of revision surgery. That meant requiring a repeat hip or knee replacement, and also a statistically significant reduced risk of requiring a blood transfusion in the patients that were receiving GLP-1 receptor agonists. This was at 90 days post-operatively. We found no statistically significant difference between the groups in risk of respiratory complications, acute kidney injury, aseptic loosening, deep venous thrombosis, emergency department visits, hematoma formation, periprosthetic fracture, or sepsis at 90 days. So to summarise, we found that GLP-1 receptor agonists were generally safe to use prior to hip or knee arthroplasty surgery and have the potential to play the role in preoperative optimization strategies. I must highlight that the certainty of evidence for these findings was low using the grade classification, and thus prospective studies are needed to validate these correlations. I just want to take this opportunity to thank you all again for listening to my presentation, and apologies again that I couldn't attend in person.
Hello. I'd just like to invite our next speaker to the stage, Ainsley Stewart.
Great, good afternoon everybody. I'm Ainsley Stewart and I'm a master's student in Rehabilitation Engineering and Assistive Technologies. I was born and raised in Canada until I moved to London about 4 years ago to do my bachelor's degree in biomedical engineering. Of course, being from Canada, I love ice hockey, and that's recently turned into love of hockey since being here. But enough about me, on to my project. So about 552 million traumatic amputations occur worldwide every single year, with trauma being the leading cause of upper limb amputation. Now, 5,200 upper limb amputations occur annually just in the UK, and some of these individuals will choose to use a prosthetic limb. Now, some complications with these prosthetics can lead to frequent clinic visits, which poses a financial burden on the NHS, as well as a mental and physical burden on the individual themselves. Prosthetics have a 44% abandon rate, and this is due to a couple things, but mainly due to discomfort at the site of attachment and limited control. Now, osseointegrated implants have been developed to facilitate ease of attachment by using a skin-penetrating titanium rod onto which the prosthetic will attach, and this will bypass some issues with traditional prosthetics, as we can see here, like skin irritation and pressure sores. Now, if users could receive feedback akin to that of intact limbs, the control would increase, and therefore abandon would decrease, and they would be able to return back to work and society. Now, some forms of feedback include using myoelectrics. However, this is quite limited, especially if individuals have any issues with muscle atrophy or superficial skin conditions. So my research group is looking at the use of vibrotactile feedback for prosthetics connected via osseointegration. Now, what does that mean? Think about when your mobile phone buzzes because someone's calling you or they've sent you a message. You're able to feel that vibration, distinguish between, and respond accordingly. And that's what we'd like to replicate. So one of my colleagues in my group has determined a minimum detectable frequency, as well as a maximum tolerable value for these when applied to the humerus. And this is what we'll be using in my project. So we can see over here a cross-section of the implant, with the top being where it leaves the skin. And this skin-implant interface is really important to prevent infection. Now, previously published studies from my group have shown this, and shown that the fibroblasts in the dermal layer must attach to that titanium rod in order to prevent implant failure. So we have to ensure that any control or feedback mechanism isn't disrupting any attachment at this layer. We know cells will respond to mechanical stimuli, but if it's causing cell death or decreasing attachment, we know this isn't a viable form of feedback. So I get to do a very exciting project to assess this, and I'm building a bioreactor that will assess the effect of vibrations on these cells. Now, it has been very challenging to get electronics into the hot and humid conditions of an incubator, but we have found a waterproof speaker that we will attach to a custom acrylic mount that will house a 24-well plate. Inside each of the wells, we'll be growing the cells on surgical-grade titanium discs that will be housed in custom inserts that will be used, one, for easy removal of the disc for visualization, as well as for decoupling the vibrations. Now, I'll go through my protocol 3 times at 50, 100, and 400 hertz, applying vibrations intermittently throughout about a 7-hour period per day, and then I'll assess the proliferation, viability, morphology, and attachment of the cells at 24, 48, and 72 hours, stopping at that 72-hour point, as this is that critical initial attachment point. Thank you.
So we'll just move on to questions.
I've got one question just about the literature surrounding vibration on cell lines. So what currently exists, and like what has been shown to perhaps affect the proliferation of cells previously in the past, and as a rationale for this study?
So we know for osteoblasts, they actually respond really positively under mechanical loading due to Wolff's law, but there actually hasn't been a ton around fibroblasts specifically. There has been research done with vocal fibroblasts, and they have also been found to slightly proliferate, not a ton, not nearly as much as osteoblasts, but a little bit. So we're hoping that the same thing will apply here to help seal off that interface.
So if these vibrations are safe for the fibroblast, what do you think the next barrier for the clinical translation?
Yeah, so once we are able to determine if the vibrations are safe for the cells, then we would be able to apply the vibrotactile feedback through the prosthetics so that the individuals can regain kind of that sense of control and sensory feedback. But we have to make sure that it won't cause any like issues at the interface so that we can prevent infection and
You mentioned earlier that surface level skin conditions and muscle wastage are a problem for the previously used methods. Mm-hmm. Would this at all affect the patient's ability to sense the vibrations? And is there a point where you think the vibrations also wouldn't be able to bridge this gap anymore?
I think because we attach it, can I go back a slide? I think because we're attaching it like straight through, this is for an upper limb one, but like straight through the humerus, the vibrations would be felt like directly by the bone, so then you don't have to go like through all the superficial issues that you would with a prosthetic attached that will cause issues like that.
Hi, nice talk. So I wanted to ask a question about the quantification of the magnitude of the vibrations, mm-hmm. and how essentially in your experimental configuration they would differ from whether you're coupling them directly to a patient.
So sorry, can you repeat the question?
Yeah, sorry. So have you made an effort to quantify the magnitude of the mechanical vibrations?
So we're basing that the bioreactor is applying, like quantifying that is actually what it's. We're currently doing that right now.
Okay.
Like assessing to make sure.
What technique are you using?
We're going to use laser vibrometry.
Okay, good. Yeah, that's fine. Yeah. Okay, thanks.
Any other questions? No? Okay, thank you. Oh, is there one more? Oh my God, sorry.
Hi, Ainsley. I just wanted to ask you, is the titanium disc, is that pure titanium?
The surgical grade titanium.
Okay, yeah. Cool. And would you know if the surface will be smooth or rough?
It'll be a smooth surface because I'm polishing the top of the discs at the moment.
Okay. Just wanted to ask that because it might be interesting to look at the attachment using SEM instead of vinculum staining again. So, but we can talk about that.
Thank you.
Thank you. Great talk.
Thank you so much. So we'll be moving on to our next speaker, Rania Darwish.
Hello everyone, my name is Rania and this is my research about dermal scaffold in complex extremity wound reconstruction. And this is a systematic review to study the impact of early application for the scaffold on the extremity wound and how it can downgrading the later reconstruction. Who I am? I'm Rania from Syria. I'm reconstructive brain and plastic surgery. Syria war has introduced this field to me because I have worked with thousands of burn and war injuries, and that's why I'm passionate about always bridging reconstructive practice, especially burn, with evidence-based innovation. And this study was mainly about focusing on biodegradable, temporizing materials. I focused on Integra, Matriderm, and Pilanic, which are mostly increasingly used in reconstructing the burn injury. It's I studied the complex extremity wound in upper and lower extremities with an exposed bone, polyvascularized tissues, and often unsuitable for direct grafting. And here where the role of the scaffold became to fill the gap between the wound and the later grafting and the flap, and to see how much it can replace it. And yes, I focused on three types of outcome: reducing the burden. In rarely case, we had completely avoiding the later on graft and flap, and in some case, just delayed and size reduction. Yes, and the conclusion of the research that the dermal scaffold appears to simplify the reconstruction in most of the cases rather than replacing it. I studied 411 injuries. All of them are burn and trauma, without any kind of other injuries. And among of those 411 cases, I have 307 that the scaffold helped them to, the wound to be able to be grafted later on. Only 38 with totally graft avoidance. And this is something that is promising in this field of biodegradable materials for healing the burn injuries. So it's, but for now, it's just only simplify the reconstruction with a high promise for replacing it with more kind of biodegradable rather than scaffold or dermatics or Pilanic type that I studied. So yeah, this is my study. Thank you so much.
Thank you very much, that was fantastic. How did you decide which wounds to include in your study? Because I'm sure there's a vast range of things that you can treat with this.
Yeah, I selected only trauma cases without any other kind of injuries, like without any infection, clear one, and burn cases, burn and trauma. So based on this kind of injuries I selected, because scaffold mostly worked on clear wound rather than infection and exposed or complex one.
Thank you.
Yeah.
I have a question. How did you account for changes in wound size, just to understand which one's the most which one has the most efficacy, if that makes sense?
Yeah, based on the wound size, I took all the wound sizes that I had, if it fits the criteria for the type of the wound. But the result came that when we can completely avoid the graft and the flap, it happened when the size of the wound is small, especially on the fingers and on the hand. This is where most of the cases of replacing the graft was noticed.
And then also, did you look at cases of infection as well?
No, I excluded all the infectious cases. Yeah, to focus just only on the burn.
Okay, thank you so much.
Thank you.
I'd like to introduce our next speaker or presenter to the stage, Guanzong Li. Do we have Guanzong Li? Okay. Can I invite Shana G to the stage? Is this your presentation? Yeah. Okay. Does it come with speaker notes here? This. Yeah.
Good afternoon, everyone. My name is Shauna, and today I'll be presenting my prostate cancer thesis project. A little bit about myself. I am Singaporean, and I grew up in Hong Kong before moving to the UK for my university studies. I did my undergraduate degree in biomedical sciences at the University of Southampton before coming to UCL here for my master's in nanotechnology and regenerative medicine. Outside of studying, I enjoy running. That's me after my first ever half marathon, and when I'm not running, I am baking because I like baking. Now on to my project. Prostate cancer commonly spreads to the bone, and the bone tumor interactions are still not fully understood. That is why we wanted to develop a model that better represents that environment where the prostate cancer spreads to the bone. And the aim of our project is to develop the 3D tumoroid models to study how the prostate cancer cells grow and invade in different microenvironments. We used two different cell lines, PC3 and LNCAP. PC3 is derived from bone metastasis, and LNCAP is derived from lymph node metastasis. We hypothesized that these two cell lines would show different growth and invasion patterns, and also that the 3D models will reveal behaviors not seen in 2D. And the final hypothesis was that the bone stromal conditions will promote a greater invasion compared to the acellular conditions. The cancer cells are placed into a central tumor mass, which is then surrounded by either the acellular stroma or the bone stroma. And our overall goal of this whole project is to generate a more realistic preclinical model for studying prostate cancer bone metastasis. And for my project, I focused on two outcomes, growth and invasion. First, to assess growth, I did the doubling time for the 2D and 3D cultures, as the doubling time is the time that it takes for the cell population to double. And so having a shorter doubling time would mean that the cells grew faster. So here you can see in the PC3 cell lines in the yellow color that it has a much shorter doubling time compared to the LNCAPs in the blue in the 2D, meaning that the PC3s worked really well under these conditions. However, in the 3D, we can see that there's not that much of a difference between the two, showing that the 3D environment does change how the cell behaves compared with the 2D. Now, to assess the invasion, we used the compartmentalized model. And this was measured after 21 days. We measured how far the cells invaded into the surrounding stroma. for the PC3s, which are bone-derived metastasis cells, we could see that the bone invasion is significantly higher compared to the acellular stroma invasion, which suggests that the bone environment did play a part in promoting the invasion. And for the LN caps, which are cells derived from the lymph node metastasis, we can see that there's a slight increase in the bone invasion into the stromal compartment, but that was not statistically significant, so that's consistent with LN caps behavior as a weaker response to the bone environment. Overall, the PC3 cells showed a faster growth and greater bone stromal invasion to the LN caps, and since this is still an ongoing project, we're planning to put the PNT2 cells as a normal prostate epithelial baseline comparison to see how different the cancer cells behave compared to non-cancer cells. Thank you for listening.
I'm going to open the floor for any questions.
Thank you, nice talk. You mentioned that you've done studies in a compartmentalized model that was essentially a cell-free periphery, right? Full of collagen. Yes. Moving forward, would you consider adding stroma cells like cancer-associated fibroblasts in the periphery, and how you would expect potentially the invasion to change?
So originally the plan was for a multi-compartment model, so there would be three masses in the middle where like we have a PC3, LN cap, and bone nodules, but my time for my project is too short, so I can't do that. But yeah, we could look into that as well.
Very interesting. What component of the bone stroma you think is mainly driving the increase in the PC3 invasion?
I think because PC3s are bone-derived cells, they would naturally grow towards like the bone stroma because of the bone-like environment. Yeah. No, not specifically, no.
Thanks for a good talk. I was interested, have you looked at any attachment parameters with your cells? So looked at integrin expression or focal adhesion expression in accounting for your 2 and 3D system differences?
We're currently working on staining and looking at the imagings, but yeah, that's still under our process because we have not been able to stain them quite well recently.
Okay, good luck with the staining.
Thank you.
Thank you. I'd like to invite Joanna to the stage. Sorry, Joanna just went. Sorry, Joanna. Philip. Yes.
Want to go twice? Awesome, thank you very much. Perfect. Hi. My name is Philip Benedict, and today I am very excited to introduce the research that I've been doing under the supervision of Dr. Peter Snow, sat in the corner over there, during my time here at UCL. During this brief presentation, I'm hoping to outline how our project focuses on cutting-edge development of surgical training, and how VR can succeed where the historical see one, do one, teach one approach has failed. There we go. But before we get into the nitty-gritty, here's a little introduction to me. I'm a fourth-year medical student from Brighton Sussex Medical School, currently intercalating a master at the Stanmore campus, which is where I've been very lucky to be able to deepen my love for orthopedic surgery. In line with the common orthopedic stereotypes, I also have a personal interest in high-performance biomechanics through my competitive background in powerlifting and my really not competitive background in Muay Thai. Combining my medical training with a lifelong interest for video games and simulation technology, I became fascinated by the rapidly developing field of orthopedic robotics after my first time being able to watch a robotic knee replacement at the RNOH here. Hence, a possibility of contributing in this field by exploring how we can successfully integrate VR and haptics to fundamentally improve early-stage orthopedic training was what made this project so attractive to me. So this brings us to our core challenge. Traditional orthopedic training relies heavily on time-intensive, high-cost, and low-repeatability methods, both in the operating theatre and in cadaveric labs. The only alternative really being low-fidelity simulators with high-cost consumables and really poor overall immersion. As shown by previous studies, there's traditionally a really steep and predictable climb in technical skill from a novice all the way to consultant in surgical specialties. However, achieving this proficiency often involves high stress exposures and real-life complications for patients, calling the ethics of such approaches into question more and more. This is where our project introduces an alternative paradigm. By developing a hybrid VR simulator, we aim to flatten the learning curve. Our primary hypothesis is that we can achieve an equal or even accelerated progression curve for trainees compared to the standard training pathway, all within a safe, simulated environment that can be repeated an unlimited number of times. In addition, the simulator's capacity to provide objective performance metrics would allow supervisors to find the exact point when they're happy for a trainee to progress to real-life training. So, to test this hypothesis, our methodology integrates 5 core components. First, we have built a virtual surgical environment in Unreal Engine 4 around the traditional dynamic hip screw or DHS workflow. Secondly, which is where we currently are, we are integrating the Hapley robotic system to provide physical haptic feedback, which we believe is one of the most integral parts to the learning process. Third, we will establish a physical layer by modeling and 3D printing core components to be held in the trainee's non-dominant hand to create an even greater sense of immersion. Fourth, a rigorous calibration system will see clinicians with different amounts of experience testing the simulator. We expect our data to demonstrate a clear correlation between surgical experience and performance in the simulation, validating the platform's accuracy. Finally, during the data collection stage, we will record hand movements, force sensor metrics, procedure logs, and technical errors made by novices using the simulator. Comparing their performance across repeated attempts and hopefully multiple days, we are hoping to map them along the calibration curve and see them progressing at an equal or even hopefully accelerated rate compared to standard surgical training. Ultimately, and this is really, really important to me, we are not trying to replace standard surgical training. We are trying to make the first mistake happen in the simulator and the first operation happen with confidence. Thank you very much, and if you are interested in learning more or even getting involved in the program, if you are a novice in the field, feel free to scan the QR code on the screen. Thank you.
Questions?
Thanks, Philip. Great presentation, really interesting work. I think one of the challenges that we come across with sort of this simulation is the validity of that simulator for replicating the real world. There's always going to be some gap there. And I think in some of the literature, you get some surprising results when you look at experienced surgeons then going back to the simulator. So I'm just wondering, for this kind of step 4, which looks like your calibration, have you thought about that challenge in terms of how you tackle that validity of the simulation?
Yeah, that is actually a point that's going to be really important to us. So we're working very closely with a team of surgeons at the RNOH who have been helping us in the process of coming up with this idea, but also their major part is going to be in that 4th stage, which is where we're going to have them come in, try the simulator, and listen for their feedback. So little changes in this bone doesn't feel quite hard enough, this isn't realistic in terms of how we are able to move this. These will be key for us to calibrate the system and improve the validity. And then secondly, by having access to clinicians of different experience levels, we are hoping to get them to do the simulator, and then if we are lucky enough to get a nice calibration curve going the way we wanted to, that we are hoping would serve as validity of our simulator.
Thank you.
Thank you for the talk, really interesting. I'm interested actually in trying this. So the question is, who are you recruiting exactly to try it?
Yes, so that's what the QR code's for. Scan it if you'd like. We're in early stage, so it's just your name and stuff. But yeah, so we are recruiting anyone who's a novice. So we're going to, we have a link to the Surgical Society here at UCL. So we're going to go for medical students there primarily, but also anyone with a medical background but no training on this specific field would be allowed to take part.
Okay, so like what value would a beginner provide to this study exactly?
Oh, okay, so because the whole point of this is trying to compare if our simulator can provide the same quality of training that real-life training can. Not to replace it, but as a stage before to increase the safety of actual learning and training. So we are then, for a novice, that's fantastic because they have no idea about the procedure. We give them a little brief, and then they get to attempt it. So we can, on them, see how with multiple attempts, how hopefully their skill in the procedure through the metrics, so through their timed performance, through their error rates, through like no injury, no iatrogenic injuries, we'll be able to track how they are improving and hopefully show that they're learning, not just to play the system, but also to learn how to do the actual procedure.
Thank you.
Thank you. I'm actually going to follow like Tom's question. You said you're working very closely with a group of surgeons. My question, two questions actually. How are you planning, or what are the platforms you're using to validate the realism of the haptic feedback? And moving forward, why you guys are thinking how to show this and the skills that they have learned, how you see it translating into the real surgery life?
So for the first question, we are going to rely heavily on the surgeons as a gold standard and on their experience of how real tissue feels. So we are using within Unreal Engine, there are baselines for this and there are models which give you a sort of estimate, but we're going to work very closely with the surgeons there to fine-tune it because we assume they have done this a million times before, so they will know exactly how it's supposed to feel, and I think it will stand out to them much more than it would stand out to us from the first moment they touch it, that it feels wrong.
You don't think this might be a bit subjective?
Well, of course, but we're hoping to use, like I said, multiple clinicians. Again, you're never fully, and this is what Tom, I think, was saying earlier, you'll never fully be able to objectively recreate real life because not every patient's bone is going to feel the same, quite frankly. So by using multiple clinicians with vast amounts of experience, we're hoping to get the best estimate. We're not claiming that we're going to get a perfect equivalent. Yeah. I think she's got the microphone.
That's okay. Can I go ahead?
Yeah, absolutely.
Just very quickly. Just in my understanding of the surgical environment, which is not just the technicalities, and you want to get good all-round surgeons coming out of their training, of course. So I wonder whether you're planning in the future to do any comparative studies between the simulated trained surgeons and the non-simulating trained surgeons.
Well, that would be the dream. I mean, for now, we're using our calibration curve throughout the standard surgical training pathway to compare. But obviously, yes, absolutely, the ideal would be to, in the future, have medical students who are training in the standard training pathway and people who are training in our environment on top of the standard surgical pathway, and then compare directly. But that is a couple of stages.
In the future. Can I suggest that you use performance anxiety as well as one of your outcomes?
It is actually one of the measures we've got in our questionnaires, yes.
Great,
just
thanks.
If there's a time, just a quick one. What if you find an expert video player
so
tops the list and is much better than orthopedic surgeons? Would you get operated by them?
So I'm going to be really honest with you, this is one of our biggest fears. But we are through our selective criteria and also through, we've got quite extensive pre- and post-session questionnaires. We are trying to make sure these confounders don't affect our data. So if we have questions on video game experience, we've got questions on things like DIY as well, which is something that was suggested by the surgeons. And so we're going to definitely look at that and make sure that doesn't slip between the lines. And if it is completely uncomparable, they will unfortunately just have to be... Yeah, but that is it's a very good point, especially with VR. Like people doing it the first time, it can be very disorientating. And also some people struggle with nausea. So this is something we have to account for. But yeah, we're trying our best.
I have a quick question.
Absolutely.
So I really like this idea about providing feedback, but I wanted to ask whether the feedback was mainly numerical or whether you'd be giving word feedback as well. And I think another thing, as someone who's tried like another VR, sorry, not VR, but like they video record the surgery that you're doing,
yeah,
and then provide you feedback. But the feedback that you get is like, okay, maybe you were a bit slow or you were imprecise or whatever. But I didn't find it as useful as if I could have gone back to that part of the video that I did that mistake, and actually, like, if you could refer specifically to that mistake in that video. So I was wondering whether that was something you were thinking about in terms of feedback.
Yes. So we have the numerical values, but we are dealing in X, Y, and Z coordinates here. So that wouldn't be particularly useful to the end user. But what we're working on is that each time when you finish a simulation, you get a summary. So this will include things, obviously, like the amount of time you took, but also the amount of X-ray shots you needed to get your position. You will be able to view those X-ray shots later on. We'll be able to tell you exactly when you veered from the path that you were trying to be on. We'll tell you your distance to target, so how far you've managed to bring a guide wire in without plunging out the other end. So we'll be able to use those, and then we're hoping to, at the end, give you a summary of all of your sessions, basically a printout or as an email, and then send you a nice, so this is how your performance changed, this is the thing you have to work on the most to improve, to hopefully take out some of what we've experienced ourselves as the subjectivity of feedback in medical training. Because like you say, often you just get well, you could have been a little bit faster, and you're like, right, but how do I do that? So we're trying to bridge that gap between the person telling you what to do and how to actually improve.
Thank you. Okay, thank you so much.
Thank you very much.
I'd like to invite our final speaker to the stage, Mudad.
Okay. Hello, everyone. My name is Mudar Joudieh. I'm a Syrian medical doctor who studied medicine in Syria during the wartime. This gives you exceptional experience, just like Rania mentioned before me. I am one of the first 4 students to get the UCL Humanitarian Scholarship. During my undergrad years, I tried a lot of things. I developed an interest in politics. I became a civil activist. I tried all types of arts. Finally, I landed on music. Now I play the bass guitar, sing, and write songs. And I do live shows too. For my project, this year I'm working on developing prosthetic limbs. A main challenge we're facing in this field is that when a person loses a limb or is born without it, there's no artificial replacement that can give them back the sense of ownership. To understand what they experience, just think about the time you had a soup using a spoon. You can't take your eye off the spoon, otherwise you're going to spill food all over yourself. Now imagine if you replace your hand with a spoon. You can't do anything without watching every single move you do. This is pretty frustrating, which led to high rejection rates among users. They believe they're better off living without a limb than having one they can't feel. So will there be a way to solve this problem for them? If we think about inducing a sense of movement while the user is moving their prosthetic limb, will we be able to help them gain their ownership back? It was found that if we vibrate a tendon or a muscle using a loudspeaker placed directly on the skin, we can induce an illusion of movement in other parts of the limb, and even in parts that are not even there. That was pretty interesting, but the research that was done didn't think about prosthetic limb designs. So they only used a large speaker that is unsuitable for it. Last year, there's a student who tested using 4 small speakers and got similar results. The success rate was up to 70%. Participants reported that they were closing their grip, twisting their wrist, bending their elbow, or a combination of all of these. What I'm doing this year is that I'm comparing different number of small speakers in hopes that we can get similar results using minimum number of speakers, hopefully 1. What I'm also doing for the first time is that I'm doing follow-ups. So I'm testing if this response gets better with time. Just like anything we do in life, with practice, it gets better. So will that work here too? I didn't get to the data analysis phase yet, but the observations I made are actually really interesting. Some participants feel the vividness of the illusion was too high. It was unbelievable to them. They ask me after we finished the test, did I move my arm? And I say, no, they don't believe it. But I'm well aware of like building expectations right now. I'm waiting until a month from now. I will do the data analysis, and hopefully I will do final conclusion. But I believe if we understand this illusion, how it works, how we can induce it, we can solve a problem for people that were deemed to have like a small market that no one is interested in. This may be a very affordable solution for them. So if you like to take part in this study and share this journey with me, I would really appreciate it. And thank you so much.
Thank you very much. I have a question sort of linking yours and Ainsley's, because, correct me if I'm wrong here, speakers at the end of the day, the way they are perceiving this is through vibration, right? Yeah. Are there any concerns with your model here about damage to the skin or issues with skin conditions and things like that Ainsley mentioned?
No, because it's superficial, it's a non-invasive method to try and create this illusion. There is no reported damage. And yeah, like other than some marks that are left, that are there for like 2 minutes, 3 minutes, because of the pressure that is put, there's no damage to the skin. Yeah. Thank you.
Thanks. So yeah, nice talk. It's nice to see that acoustics are being used in this context.
I'm sorry, but
sorry.
I don't see the person speaking.
I'm here.
Oh yeah, sorry. Yeah.
So I wanted to ask about the specific transduction mechanism of the speakers.
Can you explain?
So by which means do they convert electrical energy into mechanical energy?
It's just like any speaker we have.
Moving coil?
Yeah, exactly. Okay. Exactly.
Right. And why specifically did you hone in on these frequencies from 50 to 110 hertz?
Prior research found that there's a range between 50 and 220 that can give the illusion. So we picked frequencies that were used in a research that I'm going to compare the results with. They used these frequencies, so it's just for comparable reasons. I picked these frequencies, but what we know until now is that there is no golden number that gives the best results.
I suspect it will be patient-specific in any case.
Exactly. Well, this is the problem with studying proprioception, because it's pretty much subjective. We don't have objective measures to study the feeling of movement or the feeling of position. We hope that we can help understand this sensation more. But yeah, it relies on what the participant reports, and we are well aware that this is a limitation in the study. And yeah, picking the frequencies can be tricky, because it's all speculations now. We are trying different things. More students for the future will do other studies, maybe pick other frequencies and see how results compare to each other.
And do you have any idea how, just one last question, because this is really interesting. Do you have any idea what the mechanisms at play may be?
Not yet. We don't know. Okay. We don't know yet. Yeah. The research before was just interested in the illusion. They reported that there's an illusion of movement if we vibrate the tendon or the muscle. Why does that happen? We still don't know. So we hope one of the suggestions for future research is to do brain imaging while we're trying to induce the illusion and see what happens. Mm-hmm. But yeah, we're a bit early in this research.
Okay, thanks.
Yeah, thank you. Yeah.
How does this work? What you're really doing is producing a mechanical change and leading to a completely different sensation in the person.
Yeah, exactly.
See whether this can have different sensations like vision or audio. You can do any of that.
Well, this question leads to another discussion we've been having like for a while now, because the brain is really fascinating. How we perceive reality becomes really questionable when we start thinking about the details here. People who are born with a missing part in their limb can still feel the missing part, which makes us think, how does the brain understand the 3D model of the body? Does the brain develop separately from the rest of the organs? More so, I think Imperial College is doing a research where they're studying how many arms can a person control. And this is really fascinating. We know how to control 2 arms, but they're studying controlling 3, 4, or 5 arms, which is weird. The brain can still do that. There's research where they added more fingers to the hand and people could control them. Yeah, I'm not in a stage where I can answer this. And I'm studying musculoskeletal sciences. I now think that I'm going to, as a medical doctor, I'm going to specialize in neurology just to understand this. So yeah, it is fascinating. Yeah.
Thanks for a good talk.
Thank you.
I was just curious, you sort of touched on it with the answer previously, but do you think, I know you're using healthy participants here, but do you think you'd see a difference between those with congenital limb loss and those with traumatic limb loss?
I think, well, one difference, I didn't study the difference between them a lot, but one thing I know about people who lost a limb after trauma is that if the trauma was severe, if the accident was severe, the shadow limb is put in a weird position sometimes. And there's, of course, the psychological effect of the trauma. This all plays a role, but I'm not in a place now to study the difference between them. Yeah, it would be fascinating if we find a difference, but I don't have, let's say, a concise answer for this now.
Thanks.
Yeah, thank you.
I actually had one question about the positioning of these speakers on the short head of the biceps. So have you noticed so far any variation with perhaps greater sensation closer to the muscle tendon interface or maybe towards the center of the muscle? Have you noticed any variations in how people are able to perceive this proprioceptive illusion?
Actually, I can't rely on observations, but there's nothing so clear. I don't think there will be a great difference. But yeah, one of the limitations in my design is that whenever I'm testing with one speaker, it's the one closer to the shoulder. then the 2 is the one next to it, then 3, then 4. One of the things we discussed that later studies should randomize the speakers that are turned on. Mine are fixed, and because I have a strap and they're all stitched together, I don't change the position. So yeah, I can't answer this question, but yeah, it is valid. We thought about it, yeah, we're going to put this detail aside right now and test the rest. Yeah.
Here.
Yeah.
Thank you for the talk. I have just simple, like, basic questions, actually, 2 of them. Why do you think some participants experience stronger illusions than the others? And my second question would be actually like echoing one of the previous question. How do you know these illusions are not just simply some sensory distraction?
Yeah. Regarding the first question, the student who did the same study last year looked on the BMI scores. They suspected the BMI that maybe more fat tissue leads to more vivid illusions. They found no correlation. We also suspected physical activity. They also did a study and they found no correlation. So everything we suspected until now that may play a role in why some people get a very vivid illusion, or maybe for longer durations, higher range of motion, we still couldn't pin out a factor that is causing this. Yeah, and the second question was, can you say it again?
This illusion is not just...
Yeah. Well, we try to distract the participant as much as we can. I put headphones and I turn on white noise for them. They close their eyes so that there's no visual feedback to tell them where their arm is, but still their arm is put on a table. So there is sensory feedback from there. They also feel the temperature of the room. And we can't put that aside with healthy participants. This is what makes me really interested in doing the same study with people with limb loss, because there should not be any sensory feedback that interferes with what we're trying to induce. Still, previous research says that they got similar results between healthy participants and people with limb loss. So again, there are a lot of questions. There is a lot of research that should be done for later. Yeah, a lot of questions that are begging for research. So yeah, thank you.
Thank you. Great talk.
Yeah, thank you.
Model, it's very interesting.
Thank you.
So I got 2 questions. So I'm very lucky to be one of the participants in your research group. Although I'm not your participant, I'm one of the teammates participants. And I find really interesting is that me personally, I feel mostly nothing when I was attached to those 4 speakers, but some people might feel like significant response. And my first question is that, do you think that, I'm sorry if someone already asked that question before, what kind of factor do you think that affect the most? Could it be like the physical activity, or what kind of sport that these people, they do, and like their body weight, their muscle strength? Could that be a factor affecting their response? And second question is that, like someone already mentioned, your feedback is basically, it's mostly based on the participant response on the scale of 1 to 10.
Yeah.
But that could also be like not standardized, because everyone have different like psychological response or things like that. How do you standardize that? Do you think that putting ECG and EMG into EEG and EMG into the standardizing process, would you think that would be a future direction?
Well, it's not about muscle activity, so an EMG won't help in that. But yeah, regarding the first question, again, we couldn't point out what's the reason for the difference. The other student who's doing a similar research is testing the coordination the person has. So rather than physical activity, Can they do a bit of like a small complicated move or not? So yeah, I'm waiting for her data, her results. Regarding the scale, yes, it is very subjective. And I had participants who like told me, oh, I'm feeling a bending in the elbow, and it's 4 out of 10. Okay, then they do the move. And what I see is a 10. Like you got your elbow all here. And what is a 5 for you? If this is a 4, where do you want to go? So yeah, I'm very careful with trying to tell them what the results are, but I just guide them through. So I ask them, so what is a 10 for you? What is a 5? What is a 1? We try to decide on these numbers. Then we go with the study. Again, it's a limitation. Using subjective measures is always a limitation. But that's what we know about proprioception until now, and that's what we have. We can argue, and that's what I believe, in the end, it's about what the user feels or what the user thinks is true. It's not about the truth. At the end, they're not moving. But if they believe so, if they think so, I think this would be a success. The only catch and thing we have to be careful with is, does it change with time? So maybe they will be convinced in the beginning, maybe after 6 months, they realize that, oh, I'm not moving. Or, oh, it's just an illusion, it stops working. We don't know, and this is where the follow-ups are really important. Yeah. I hope I answered the question. Yeah, good, okay.
Okay, thank you. So that concludes...
Thank you. Thanks so much.
So that concludes session 2. We'll just be going off for a 15-minute break, and then we'll be starting session 3.
presentations, and I'd like to invite Anna to the stage to present.
Can I start? Oh, this is working. Everyone is hearing me? Perfect. So, hi, I'm Anna, and I'm in my first year doing research on computer vision and virtual reality in endoscopic spinal surgery. So about me, I'm from Hungary, and I'm a Hungarian folk dancer. I'm also a horse rider. You can see me and my horse, Leila. I'm also quite close to agriculture because of my family. And I am trying to be a good right back in the women's football team of UCL. But most of the time, I'm a PhD researcher of the Tech for Health doctorate training program, working on improving spinal surgery. So a bit of background here. Spinal surgery is usually done by dissecting the tissues at the back. So basically, doctors open the patient at the back, which is obviously very invasive. So more and more surgeons are trying to shift towards the endoscopic, i.e. minimally invasive version of this procedure, where they just insert a tube and work with their surgical tools across that tube. So this results in minimal injury, reduced risks, and obviously quicker recovery times. So we choose endoscopic spinal surgery. The problem is that it is very hard and can only be performed by a surprisingly small number of surgeons. So what I'm trying to do is use the endoscopic video, which is captured at the end of the surgical tools, and create computer vision models that would understand the critical structures, the tissues, and the tool interactions on that video. So then they can provide a structured feedback about surgical skills, risks, and about the whole procedure to the surgeons and the clinics. And the other side of this research, which is a future goal after the computer vision models are stabilized, is a surgical simulation, which is very similar to Philip's one, where surgeons could practice this endoscopic spinal surgery. And hopefully these projects will continuously inform each other. So first step is obviously to collect lots of these endoscopic videos. Then I will need to label them, to segment the tissues and label the tools on each frame, so that I can build different computer vision models, compare their performance, and hopefully proceed with the best one, which is when I will start to develop an assessment framework based on which this structured feedback would be given to surgeons, which hopefully will help them in their training process or in their development of skills. And this is where the surgical simulation would come into picture. So hopefully using the output of these computer vision models will help us build realistic 3D models of these tissues, which will provide the visualities and training scenarios of the simulation. So after this, the last step and the last phase of the project will be to add haptics. And this is a rough overview of my next 3 years. I'm very happy to connect with anyone who is doing a similar thing. And thank you.
Hi, Anna. Thanks. That was a wonderful presentation. Slightly challenging, I should imagine, as a project. And I think I'm going to ask you a similar question to what I asked in the previous session, which is, again, about that validation of your model, really, of your computer vision model. Because I guess it has to be related to eventually the surgical outcomes, because you don't really know what's good and bad unless you can actually start seeing how this procedure relates to the final kind of surgical outcome. And do you have any way of including that at this stage, or are you really just looking at modeling that tissue and the tool movement in that small space?
Yeah, so firstly, there are quite a few standards about measuring how efficient the surgeon is with the tools. So basic things such as inefficient movements during the surgical tasks could be easily measured and evaluated without measuring the outcome. But with the clinical validation, which will probably happen once the computer vision model is stable, we do plan to check the outcomes in the clinics after assessing the procedure with the computer vision models as well.
Yeah, I'm just thinking, so in terms of the efficiency of the movements, like clearly it's good to be efficient, but is there already literature that says if you're less efficient in doing those movements, does that already link to a poorer outcome, or is it just, okay, it's going to take a bit longer to do?
So I think generally there is a link between the procedure time and recovery times. So that's why efficiency of tool movement is a good indication. And there are other more obvious indications we can use. For example, blood that could appear on the camera. Yeah, but in the end, we obviously need to link them to the actual outcomes. Maybe even confirm our assumptions with these obvious links by seeing how they actually link to patient outcomes. But these are useful while I am developing the framework so that I can, obviously I need to make assumptions before getting them to the clinic.
Thanks. Good luck with the rest of the PhD.
Thank you.
Thank you very much for your talk.
Thank you.
So I'd now like to invite Ahmed to the stage.
Hello everyone, my name's Ahmed Al-Sayed. I'm a second year PhD student and I wanted to talk to you today about, sorry if anyone's heard this talk before, I can see a couple of faces, about what happens when AI-enabled endoscopy goes wrong and causes patient harm and who takes responsibility for that. In terms of a bit of background, I'm a gastroenterologist normally and my PhD is about implementation of AI in endoscopy. I used to be an amateur boxer, and now mostly play paddle and tennis, mostly so I get punched in the face a bit less. And I'm about to become a dad for the first time in a couple of months, which I'm very excited by, also slightly concerned about managing that with a PhD. In terms of the background to this particular study and why we thought it was interesting and worth pursuing, the use of AI is obviously seeing increasing usage across healthcare and across endoscopy in particular. But despite that, we know there haven't yet been any medico-legal cases involving AI in endoscopy. So we wanted to examine how responsibility or liability is assigned in AI-assisted endoscopy when harm occurs, and also to ask how automation level influences that responsibility as well. And automation level, apologies, I don't think that graph has come out very well, but in the top right corner, automation level essentially refers to how independent the AI is, and how much oversight the human has over the AI. The higher the score, the higher the level of automation. And we mapped our 3 scenarios that we asked participants to review along that scale. We asked 500 participants, 500 members of the public, to rate the level of responsibility for 4 parties: doctor, hospital, AI manufacturer, and a no-fault compensation scheme for 3 different scenarios. And the no-fault scheme being a scheme that's operated in some countries, which means that a patient can claim financial compensation when harm occurs without anyone having to be proven to be at fault. So we had 3 scenarios. The low level of automation was a computer-aided quality system. This was a system that showed a mucosal visualization score for the endoscopist, in this case showing a score of 86%, which they were satisfied by. They scheduled a repeat colonoscopy in 3 years' time, but the patient developed a post-colonoscopy colorectal cancer. Next, we had a medium level of automation, or a computer-aided diagnosis system. This is a system that detects and diagnoses, so it does more things, it does 2 things. And in this scenario, the endoscopist found a diminutive rectal polyp, a less than 5 millimeter rectal polyp, which they initially classified as hyperplastic. They then used the AI system, the CADX, to classify it, which agreed with their assessment, and they therefore left it in situ under a so-called diagnose and leave optical diagnosis strategy, which is a well-known strategy in endoscopy. And the patient unfortunately developed, again, a post-colonoscopy colorectal cancer. Finally, the high level of automation scenario, the capsule endoscopy scenario. Obviously, at the moment, when we use capsule endoscopy, a doctor has to look at all the individual images. In this system, the AI system looks at all the images itself. If it analyzes all the images as being completely normal, then a doctor never has to look at the images, and it just sends an automated report to the healthcare records saying that the images are all normal. In this one, the AI system failed to detect a small bowel bleed for a patient, which led to delayed treatment and eventually surgery. In terms of what we found, so we had just over 500 participants split evenly between the US and Europe. And we found, unfortunately for us, that doctors are seen to be the most responsible overall. You can see here the mean score of 5.15. And actually, the no-fault scheme, which we thought might be a bit more popular, especially at high levels of automation, was generally rated very lowly across all the scenarios. However, that wasn't a universal approach, and the level of automation did affect how responsibility is attributed. And you can see here the top line, the dark blue, the doctor. As the level of automation goes up, our responsibility goes down, whereas that of the institutions, i.e. the hospitals in the orange, and the manufacturers in the green does go up, and it peaks at the higher levels of automation. For us as endoscopists, this means that currently available licensed regulated tools don't seem to protect us medico-legally. And in fact, some of the novel metrics, for example, mucosal visualization is a novel metric for us, may actually increase our medico-legal risk unless we also develop accepted minimum validated standards alongside them. Thank you very much.
Yeah, I just wanted to, first of all, thank you for your talk, and then ask about how you think that use of AI and in the public's perception, especially, will that have any effect on like translating this technology into practice? Do you think that there will be people who are opposed to the knowledge of use of AI in their diagnosis or their treatment pathway?
I think so, and there's been quite a few studies in endoscopy in particular looking at patient acceptance of things, including optical diagnosis, for example, for which, so the CADX system is seen as one of the ways that we can most implement AI in endoscopy through the diagnose and leave and resect and discard strategies. And there's been quite a few surveys asking patients in studies how acceptable they find that, and actually it's seen quite high acceptability so far. And for now, most of the time we don't enact those strategies, we don't use the AI if the patient doesn't want it used during their endoscopy. So patient acceptance is definitely a big factor for us, yeah.
In terms of, obviously, waiting lists and in terms of staffing and the ever-growing patient population that we're going to face in the coming generations, do you think it will become less of a if the patient wants us to use it, we'll use it, and more of a it is our standard care? And do you then think the number of, for example, the jobs that you're doing will then decrease and medical assets will be redirected in other situations?
Yeah, I completely agree. I think as AI becomes more standard of care, in the same way that we don't necessarily in endoscopy ask a patient whether they want a cap or an endocuff placed on, we would just use AI. And the same with optical diagnosis. It's been in place for a few years now. Not many countries do it. The NHS bowel cancer screening program is one of the first to implement it. And we're also looking to be one of the first to use CADX regularly while using it. And I think going forward, once that becomes standard of care in the NHS, it's not going to be something that people can necessarily opt out of. Thank you very much.
Thank you very much. We'll be hearing from Conrad.
Okay, can everyone hear me? Okay, great, thank you. So I find it difficult talking about myself, but I've included this slide like everyone else. So I'm a PhD researcher at UCL, investigating the interactions of electricity with cancer cells. But I'm also an NHS surgical trainee. And while I'm not in the hospital or the lab, I enjoy eating my dinner in front of the TV, watching a good film, heading to the gym a couple of times a week, and I'm also part of a board game club, so I go and play board games a couple of times a month. Here we go. So my project, or part of my project I'd like to present is irreversible electroporation, or IRE, driving gemcitabine sensitization in pancreatic ductal adenocarcinoma. So irreversible electroporation, or IRE, delivers high voltage pulses between electrodes placed around a tumour, and it's been used clinically and in trials for prostate, melanoma and breast cancer. This causes apoptosis, but also creates nanopores, which are known to increase drug uptake. Gemcitabine is used in all stages of pancreatic cancer. It enters the cell via transporters, predominantly HENT1, and is phosphorylated via the DCK enzyme to its cytotoxic triphosphate form. Unfortunately, response rates are quite low, only 30%, and proposed mechanisms of chemoresistance are low HENT1 and low DCK enzyme levels. In the literature, combining gemcitabine with IRE has been shown to significantly improve median overall survival. But a gap in this knowledge is that no clinical trials have specifically examined gemcitabine in resistant cell lines. But it's possible that patients with low HENT1 or low DCK enzyme could gain the most from combination of IRE and gemcitabine by enhanced drug uptake and subsequent alterations in drug metabolism. So we decided to test this theory on PANC1 cells, which are a gemcitabine-resistant cell line. We seeded them at a density of 5,000 cells per well, and the experimental conditions included untreated controls, IRE monotherapy at its IC50 dose, gemcitabine monotherapy across 6 concentrations ranging from 1 to 100 micromolar, and finally a combination of therapy of IRE plus gemcitabine at the aforementioned concentrations. So after 24 hours of incubation, the gemcitabine-containing media was removed, cells were washed to eliminate residual drug, and fresh media was added. Metabolic activity was assessed at 3 time points post-washing, at 0 hours, 24 and 48 hours. To quantify intracellular gemcitabine and its metabolites, liquid chromatography mass spec was performed for control gemcitabine monotherapy and combination therapy. The respective master charge abundance was read off the LCMS graphs and compared across the conditions. So it was the 48-hour time point that showed all concentrations tested when combined with IRE produced a statistically significant reduction in proliferation compared to monotherapies alone. So the red columns are IRE, and then the blue columns are just the gemcitabine. But you see when you combine them, you get this statistically significant reduction in proliferation, which is basically telling us that both treatments combined together work in synergy. The actual concentration of gemcitabine did not significantly influence the extent of metabolic suppression, indicating that the sensitizing effect of IRE is robust across all the doses tested. When we look at what's happening with the gemcitabine intracellularly and how it's being metabolized and its metabolites, we prove that IRE increased in abundance in the cell when combined with IRE by 3.24 times. The parent drug decreased to 0.51 times, but the active triphosphate metabolite was increased by 11.6 times, demonstrating positive cooperativity and suggesting that IRE changes drug metabolism. So more parent drug was metabolized to its cytotoxic form when IRE was used. These results suggest that combining IRE with gemcitabine can resensitize resistant cancers and could theoretically improve overall survival in these cases. Thanks very much for listening. Any questions? Oh, yes. Hi.
Have you considered using even a smaller
No, I agree. When we actually just did our monotherapy, they were all completely resistant from 1 to 100. So we were like, well, we should probably start at 1 because 1 hasn't shown anything. But I agree, actually, seeing the lowest possible dose you could use. Yeah, no, I agree. That'd be a good idea, yeah. Yeah.
The dumb engineer question. The original treatment,
Yeah.
you put a couple of guide wires into where you locate the centre of the cancer. And just hit it with a nice big voltage power?
Yeah, so clinically, patients transcutaneously have 2 electrodes placed under CT guidance, and they get put around the cancer, and then the voltage goes between the 2 electrodes. It's about 1500 volts. Now, I forgot what I was going to say. Yeah, it's about 1500 volts. Now, the good thing about IRE is that it works on voltage potential changes, so it doesn't actually use heat like a lot of other treatments. And this is important in the pancreas and the prostate, where the cancer actually grows around structures you can't remove because that would be incompatible with life. So there's less damage to surrounding structures just because it works on voltage changes.
Thank you very much for those questions as well. So now, please, can I call Daniel up to present?
So hello everyone, my name is Daniel Silva. I'm a PhD student here at UCL. Sorry, there's a bit of technical difficulties, a little bit slow. Okay, yeah, so I am originally from Vila Franca de Xira, so a small town outside of Lisbon in Portugal. So if you ever want to go out for a summer holiday to a place that's beautiful and quiet, I will highly recommend it. Emphasis on the quiet, because Portuguese and being quiet don't really go hand in hand, so you've been warned. And my project is focusing on using low-intensity ultrasound on biomimetic models of breast cancer. So as many of you all know, that breast cancer is the primary malignancy diagnosis in women worldwide, and is also the primary cancer-related death in women worldwide. Throughout the development of therapies that are available, we have really good survival rates, but the problem is inequality of life. They're very systemic and invasive when it comes to these treatments, so it negatively impacts their life quality as they progress from a cancer patient to a survivor. Now, low-intensity ultrasound has become a potential contender to alleviate some of these issues, it being non-invasive and non-ionizing, and a lot of studies have demonstrated that you can actually selectively target cancer cells and leave your healthy ones relatively unharmed. The issue is that these studies tend to be very simplistic. They rely heavily on 2D cell cultures, and tumor is a very complex environment. And there's also the problem of the lack of reporting of your ultrasound parameters. So it makes it very difficult to not only compare these studies, but also trying to understand what the mechanism is. So my project is essentially trying to take into account some of these problems and put it more in a physiologically relevant tumoroid model. So how we did this, we generated a tumor model consisting of MDA MB231 triple-negative breast cancer cells, and these consisted of a central tumor mass in the middle surrounded by either a stromal compartment of healthy cells, and the data I'm presenting today is just an acellular stroma. So we're just specifically focusing over MDAs in the center with nothing interfering with them apart from inside the collagen gel. We treated these tumoroids for 7 days, every single day for 10 minutes at varying acoustic pressures from 0.17 megapascals to 2.5. just for simplicity's sake. It's a lot more complicated than that when you take into account frequency and duty cycles and pulse repetition frequencies. And we did this by placing our tumoroids underwater in front of a characterized focused transducer using a needle hydrophone, so we know what it actually is given out. And we initially focusing on trying to check viability by itself. Studies show that we expected to see a drop in viability, but the results we got so far are fairly inconsistent. There are some cases where we've seen a drop in viability, but it's not really reproducible enough, so we tried to shift the focus onto other biological responses. Interestingly enough, we tried to look at the sniffus values of our tumoroids following treatment, and we have seen that in our treated samples, you actually have an increase in young modulus, suggesting an increase in a stiffer cellular phenotype. And additionally, supplementing that, we have an increase in oxygen availability 24 hours after your treatment. So we have that gradual reduction of our tumor necrotic core being alleviated. To try and understand what's going on underneath all of this biologically, we did some RNA sequencing, luckily, across all our samples. And this is just simplistic top 10 genes across all our samples, because it can get quite overwhelming because you have hundreds to thousands of genes to look at. And what we see is like a pressure-dependent transcriptional, translation response, where as you increase the pressure of your ultrasound, you start inducing pathways or inducing genes of pathways that increase mechanical transduction sensing, matrix remodeling, inflammation, and even oxidative stress. So taking this all together, we're not directly inducing cytotoxicity, but rather causing a mechanical adaptation of your tumor, which is quite beneficial when it comes to try and exploiting some of these weaknesses that then make it vulnerable for your tumors for additional forms of therapy. And with that, thank you all for listening, and I'm glad to take any questions. It's a little bit more complex than that. Sometimes, when it comes to prognosis, having a stiffer tissue when it comes to cancer leads to a worse prognosis. But interestingly, especially when it comes to MDAs, they're very metastatic. They like to invade. They typically soften their environment to allow them to invade in the first place. So if their environment is stiffer, it kind of will slow down their invasion. But interestingly, we can't visually see this. It might be a case that even after the 7 days of treatment, we might start slowing it down to a point if we keep it up for longer, although we're already keeping these tumors for a very long time. This is like 18 days that we grow them, then another 7 days of treatment. Other things, such as cells, obviously stop overlapping on top of each other. It starts getting in the way, but it's a little bit unknown.
Good talk. Thank you. So now I'd like to call up Davida to the stage to present.
Good afternoon, everyone. I'm Davide Maffei. I'm a urologist and PhD student in divisional surgery, and today I'll be talking to you about the work on the development project of a patient decision aid for men with localized prostate cancer. Just a little bit about me. I did my medical school training and urology training in Italy, in Milan, and then moved to the UK in 2021, where I did a fellowship in the focal therapy team at UCLH, and then began my research degree in 2023 under supervision of Professor Caroline Moore. My research focus is prostate cancer and patient-centered care, and outside of work, my passions are CrossFit, baking, which is a very common theme here, and LGBTQI rights. So I just want to set the scene about this project. When we give a patient a new diagnosis of prostate cancer, many of these men will be faced with a difficult choice. And this is a choice about what to do with this new cancer. And they are faced with a choice between different treatment options, from surveillance, monitoring, to small treatments, to very radical treatments. All of this can be effective in treating the cancer, but they have a significant different impact in a patient's quality of life. So what's currently missing? What do people need in order to make this decision? Very often, the information they've provided with are not comprehensive. They don't have all the information on all of the modern treatment options. And very often also, this information is not personalized to each individual patient. So what we've set out to do is to develop a new patient decision aid, so a website that provides personalized, patient-friendly information that can help men in this difficult decision. So we came up with 3 teams and a clinical academic research team made of urologists, statisticians, other healthcare professionals. We then also joined forces with a web developer team. And also a really important part of the project was our group of patients and carers with lived experience in prostate cancer. We had 4 phases, starting with a systematic review on patient decision aids and a preliminary PPI meeting. We then progressed to the development of all the different parts of the patient decision aid, and we put all of it into an online platform. And eventually the 4th and most important phase was when we brought the patient in to co-design together with them and ensure that all of the parts of the instruments were patient-friendly and aligned with their requirements. So the result was the bespoke decision support website, which is indeed a website to help men with a new diagnosis of prostate cancer. So what's so specific about Bespoke? Bespoke offers, first of all, comparative information about all of the main treatment options, so surveillance, focal therapy, surgery, and radiotherapy. And this information is provided in a table, very concise, patient-friendly language, in a side-by-side manner for ease of comparison. It then goes on to ask the real question to patient about what is most important to them. This is what's called a value clarification exercise, and an example is this question here, asking men to reflect on whether they're more leaning towards an active approach, so treating the cancer, as opposed to monitoring the disease and treating only at a later stage. And then we move on to the third and most important and most innovative part of this instrument, which is the personalization of the outcomes that we provide patients. So if we start with oncological outcomes at 5 years, both in terms of mortality and need of additional treatment. And this is then compared across different treatment options. And we also give a personalized estimate of functional outcomes, which is wildly different between the different options, and we discuss both urinary, sexual, and bowel domains. What I'm showing here is just one example, for lack of time, of how we present the data. So this is leaking urine at 1 year, which is one of the major side effects of most prostate cancer treatments. And what we've chosen to do is showing with 4 different icon arrays what will happen to any man with perfect current urinary function of rarely or never leaking. What would happen to them if they chose one of these 4 treatments. So all these icons are helpful in showing men and comparing and contrasting these different treatment options. So in conclusion, we know that any decision about prostate cancer treatment will always be a difficult one. And what we're trying to do here is help men have the right information in a patient-friendly way that they can use to prepare themselves for the treatment counseling consultations. And the next step in this project will be the randomized controlled trial, which is about to start at the end of the month, after a long time. And we will be testing this in against standard of care in 350 men across several sites in London and in England. So, thank you. Yes, please. Yes, we got REC approval last year. So all patients will continue to receive standard care. So what we're doing is providing access to national charity websites. So Prostate Cancer UK has got an amazing website. So we're providing access to all patients with this website, which is standard care in the UK, really. And we are giving this in the form of via an email, so to prevent unblinding to patients who are in the standard care. Yeah. And then, because we have different sites, every site will then also include any sort of information that they would normally provide. And what we're really trying to do here is not replace standard care counseling, because that is going to be irreplaceable, obviously. But really, we're trying to prepare men and their families and carers to the treatment counseling consultation, so that they can speak to each of the individual clinicians that offer these treatments and be able to have a better understanding of the overall picture, which obviously they won't have when they're first given a new diagnosis of cancer.
Thank you very much. So now we'll be hearing from Ziwei.
Hi everyone, I'm Xiyue. I'm a third-year PhD student from Aspire Create Lab. So I grew up in Shanghai, China, and then I finished my bachelor degree in electronic engineering. And then I moved to London and completed my master's degree in neurotechnology. Now I'm here for my PhD journey and to explore the interdisciplinary field of engineering, AI, and neuroscience. So my PhD is about non-invasive speech brain-computer interfaces. And the aim is to help those patients with speech impairments to restore their communication ability. So speech BCIs can decode users' intention from their brain activities and then output those intentions into a readable content like voice or text. There is a key question. What do we want to decode for silent speech? So here I roughly categorized some different types of silent speech into this coordinate system. So from overt, nearly overt movement attempts to fully covert mental activities, from passive information perception to active speech production. And what I focused is the imagined speech paradigm, which where users need to imagine to speak without any sound or movements. So intuitively, the neural pattern intensity degrades in this direction. However, which means the imagined speech is one of the hardest to decode. But it's also very important, especially for those patients with locked-in syndromes, because they already have lost their ability for motor control. So my previous study tested the feasibility of imagined phoneme decoding. And with electroencephalogram, or EEG, we are able to safely measure the neuroelectrical activities from the scalp. And the participants imagined 6 English phonemes with different extent of similarities. So interestingly, we found that some participants showed a clear consonant-vowel separation in their latent neural space. And also, with the data from 10 participants, each of them provided around 10 minutes of valid speech imagery recording pieces. We found there is a significant gamma band discrimination between imagining B versus U. So this suggested that we may be able to find some phonetic features from the EEG during speech imagery. So based on this, we did binary imagined phoneme classification with the best participant reaching the accuracy of at 78% and the average best accuracy at around 60%. So for a very small data set, it's encouraging, but for real-world application, it's far from enough. So my next step is to apply the closed-loop neurofeedback training. So we hope that by using the adaptive AI model and the user's plastic brain patterns, the co-learning progress can help improve the BCI decoding accuracy over time. And there is also an interesting question. So what exactly is speech imagery? Is it more like kinesthetic imagery of articulation movement? Is it more like auditory imagery of the inner voice, or a mixture of both? So my ongoing project is trying to break the speech imagery into smaller components and compare those different types of inner speech. And the ultimate goal is to design a speech BCI that is both user-friendly and efficient. So that's everything for my talk. Thank you.
Thank you for the talk. So I'm very curious because you use EEG to measure the brainwave of when the patient is trying to speak but not actually speaking, right? And how does the language affect the pattern of EEG? And for example, that let's say someone is speaking English as the native language, someone is speaking German, Chinese, or maybe as a non-native English speaker, how does that affect the EEG pattern, and how do you standardize those things to set a criteria for what you're trying to solve?
I think this is a very good question. So in our in this experiment, we did not separate the group for different with different first languages, but we ensured that all the participants they reached the proficiency for English language. So we know that the Broca and Wernicke area in the left hemisphere will be used for speech production and some speech progress. And the spectrogram analysis showed that the gamma band in the EEG may be activated during the speech production or in inner speech. But whether there is a different for the task language for those participants with different language background is not studied in this in my previous experiment. But I think this is a very good aspect to look into. Thanks.
I wanted to just ask as well about when you have different people who've perhaps had speech impairments at different stages in their life and from different causes. What do you think are the next steps into understanding their conditions, and how do you think you can apply this to those cases?
So the previous study was done on healthy participants because we currently don't have patient participant, but we believe that with healthy participants' data, we are able to first build a sense of which pattern should we look into the EEG, because it's very hard to collect data on patients, but it's very easy. It's relatively easier to collect more data on healthy participants, and probably we can use some transfer learning to leverage the pre-trained model on a healthy participants group to improve the decoding accuracy on the patients group. This is what we are trying to do. Yeah. Thank you.
So next up, we'll be hearing from Xuan Yu.
Hello everyone, my name is Xuan Yu, and I'm the second year PhD student in Hubin's group. And I'd like to simply introduce myself. I received my bachelor degree in China, and then I come to Singapore to do the integrated circuit design in NTU and a joint program with TUM. And besides my academic background, to be honest, I only drink with my parents in some social event before I started my PhD. However, when I come to London, I found this is a really good way to relax myself and contact with other people. And since this is an academic symposium, I list some London bars in an academic way, and hope you enjoy. So back to my PhD program. My PhD program is a real-time edge processing framework for portable epidemiology. So firstly, I want to introduce the technology of near-infrared spectroscopy. I can simply you can see that the lights that can come through our body tissue. So when the light comes through our body tissue, the amplitude or the physical properties will change. So we use these changes to determine the body situations. However, the currently most used near systems, they are so-called the continuous wave nears. They are mostly used, but it has a significant problem is that it can only calculate or measure the trends or the variation of the body tissue, but not the absolute value. So this will lead to a lot of problems, such as the cause-subject variability. Different people, they will have different biophysical tissue baseline, and also for others, the baseline will also change over time. Like my colleagues always complain to me about that. They have a volunteer and they do the baseline setting and they do data collecting, and then the volunteer come to toilet and come back, so do the baseline setting again. So to overcome this problem, we use another modality of NIRS, which is called the frequency domain near-infrared spectroscopy. So in these cases, we modulated the light sources. So in this case, we do not only detect the amplitude of the light, but also the phase of light, which gives this technology the potential to calculate the absolute value of the biological tissue. So then we can measure the absolute value of the specific biological tissue. So my method to achieve the FD system is to use the edge processing. We use the field programmer gate array. You can consider it's like a special system on chip, like CPU or GPU, but it has some properties that it can support the parallel processing, which means that it can process the data of multiple channels at one time. And so what we do on this SoC is to do the filtering and do some other traditional signal processing, like the motion artifact animation, and then we want to do the image reconstruction on this system chip, which finally we want to implement this technology in longitudinal monitoring or in some rapid injury evaluation, such as in ambulance. And that's all about my project. Thank you.
Thank you. So firstly, thank you for your really useful table on the first slide about the bars. We will be verifying that data in due course. But I'm just curious. So basically, you're saying that you think the FD NIRS, the frequency version, will reduce the need for this recalibration, as opposed to just looking at amplitude of the light. But do you have an intuition as to why? Why will we not need to do that recalibration? Because presumably you still have changes in sensor placement and all of that, which could affect it.
I think you mean, so why we need to do the baseline setting in continuous wave years? You mean I get
Yeah, because your
okay.
frequency-based version, I understand that you're trying to reduce the need for redoing that baseline in between sessions, but I just don't quite understand why.
Because every time currently they are doing like they ask you to wear a cap and then ask you to do some activities, and every time you need to do the baseline first, and because the continuous wave they can only measure the changes of the light, so so every time you do it you need to set a basic, and then they can only measure the changes based on this basic. So if we do the frequency modality, so every time it's an absolute value. It's not like the percentage changes. It's like data changes, like the hemoglobin concentration changes about several volumes, but not a percentage. So.
Okay, I understand. Thank you.
If we don't have any more questions, thank you very much for your talk. Now, please can I call Hui Shen to the stage?
Okay, good afternoon. I'm Hui Xin Yang. I'm a second-year PhD student in the Hubin group. Firstly, let me introduce myself briefly. Before joining UCL, I did both of my undergraduate and master's degrees at Beihang University in China. Outside academics, I'm really appreciate that I have my family support. Their love motivates me to keep moving forward. Yeah, let's start my project. According to World Health Organization, 1.3 billion people experience significant disability. That represents 16% of the world's population, or 1 in 6 of us. Among them, a large proportion are the individuals that are suffering from the long-term consequences of neurological disorders, such as stroke. For stroke survivors, they always have the motor dysfunction, and many of them may require the long-term rehabilitation. For the stroke survivors, at their daily life activities, such as the arm movement, walking, or even grasping, they may be severely affected. This not only gives a heavy burden on their physical activity, but also the leave heavy burdens on their families and the healthcare systems and even the society. In the procedure of rehabilitation, at this moment, we can examine the brain by the EEG, fMRI, or FNIS, and we can access muscles by the EMG or clinical tests. But the connection between the brain and muscle, the true interaction was still unclear. And stroke often causes motor impairment due to the disrupted brain-muscle pathways. So this motivates my project. In my project to investigate the connection, I simultaneously record the brain and the muscle activities in the motor tasks. Rather than analyze these signals separately, the aim is to understand how the brain and muscle interact with each other over time. At this framework, I will record the data, brain data by the technologies like HDDOT and EEG, and to access the muscle signals to the, about the muscle needs and EMG. These signals then pre-processed and transformed into significant features for further analysis. I hope by applying the coherence analysis to help us better understand the functional relationship between the muscle and brain in the motor tasks. This may help us better understand how the brain and muscle communicate with each other changes during the movement. Preliminary results showed that the task-related patterns is in the brain and muscle areas, and with the potential interactions in the motor tasks. That's all about my research. Thank you for listening. Questions?
I just wanted to ask about the coherence analysis that you're going to use. So will it be taking data just directly from the muscle signal and the brain signal and overlapping, or are you going to be creating another interpretation, so taking the muscle signal, learning what that means in terms of like a context of what actually happens to the muscle, and then comparing that with the brain? Or, yeah, what exactly are you going to do to get those two signals into one?
Yeah, currently we have established successfully established record the brain and muscle signals at the same time, and we hope to calculate the interaction with the brain and muscle signals. Yeah.
Thank you. That's really interesting work. There's been a lot of work done in terms of looking at the coherence of the electrical signals, so between EEG and EMG. And the timing is very important for that. But obviously, if you're using HD dot and NIRS, then you're looking at that hemodynamic response, which is a bit delayed from the actual movements. So have you thought a bit about how you're going to take that into account in your analysis?
I think I use the EEG and the EMG as the electrophysiological method to gain the data, and then I use the HDDOT and muscle NIRS for the hemodynamic perspective to give me more information about the interaction. Yeah, I think I will use all about them. Yeah, thank you.
Thank you very much for your talk.
Thank you.
So now, please, could we hear from Lei?
Hi everyone, I'm Lei. I'm a second-year PhD student from Department of Medical Physics and Bioengineering. I'm from Dr. Hu Binzhao's group, and my second supervisor is Dr. Ke Li and Dr. Gang Li. So I earned my bachelor degree in electronic engineering in China, and I did my master in telecommunications at UCL. So speaking of who I am, I'm a cat person, which means I'm trained in advanced negotiation skills, especially hiding my food from my cat's patrol in skiing and paragliding. So the balance of nature and work is a big part of who I am. And speaking of the balance, I'm passionate about United Nations Sustainable Development Goals and climate change actions. So several conferences I've been involved in make me strongly believe that the balance of the technology and the nature, so the technology should not only be smart, but also be inclusive, ethical, and sustainable. So the background shapes my interest in the work of bringing the technology into the real-world context. For example, the driving fatigue investigation. So the work I'm going to present is an investigation of driving fatigue with variable high-density diffuse optical tomography.
So the fatigue driving is a leading factor of the driving accidents. So the data shows that 15% to 33% of the traffic accidents may be due to the fatigue driving. And the technology used here, FNIS functional near-field spectroscopy and the advanced variant of FNIS HDDOT, which have been introduced by the other speakers. I will not go deep here, but the characteristic of its non-invasive, portable, and low cost make it ideal to address the problem in driving fatigue. So the core idea here is to use HDDOT to differentiate and classify the quantified level and the 3 fatigue-related components. The first one is the sleepiness and the juiciness, and the second one is the time on task, the cognitive fatigue, and the third one is the overload and the stress during the fatigue. And then use an AI model to quantify and classify the fatigue-related levels. And the third one is to use a real-time monitoring system to provide the feedback and maybe the safety interventions to the driving. So the aim is to provide a real-time, portable, wearable processing which is high speed, accuracy, and safe. So apart from the HDDOT modality, I also use an ocular modality, which is called PERC loss. This is to measure the percentage of the eyelid closure. So when it exceeds a threshold, typically 15%, or you can set your personalized threshold, it indicates the fatigue is happening. So this is ocular perspective, and also use the cognitive task, which is called go, no-go task, to record your cognitive performance. For example, reaction accuracy or the reaction time. So bring this all together and use a computer-based cloud processing or the microcontroller-based processing to do a real-time monitoring. So my project is to use the cutting-edge neuroimaging method, the other inputs such as the ocular inputs and the cognitive behavior inputs, and also the subjective reporting, which is to let the participants to report your skills on a scale of 1 to 9, which 1 is the fully awake and 9 is you are really exhausted and sleepy. So all this together is to explore the mechanism of the blood oxygen regulation and the fatigue during the driving, and also explore them into other applications. So hopefully, if one day we can use this future system to tell you if your cat destroy your sleep and patrol all night in the house, and if you are awake enough to get on the road, or you should stay at home and negotiate with your cats, or you are awake enough to get on the road, so get your cats into the car, make them as your co-pilots, and enjoy the journey. Thank you. Sorry?
Do you expect the device to be something like that helmet?
Yes, we have a called Lumo system with 12 tiles, so especially on the prefrontal cortex, which is part of the cognitive function of the brain. Yes. Sorry?
Do you think people will wear it?
That's a good question. I always ask about this kind of question because it's really fitted into the applications. So if people like the driving daily and go to work and back home, so people may not be willing to wear the helmet on the day, but probably we are going to focus on some specific drivers like co-pilots or the truck drivers with the heavy load, and they are really, really important of the safety of every minute, every second. So and also the autonomous system is really popular, and autonomous assisted system is really, really
useful in their daily life, but they might not be able to use for the drivers like with a heavy overload. So probably this is the application we are looking for and explore the fatigue progress trajectory during older time.
Thank you very much for your talk. So now, please, can we have each run to the stage?
So, hello everyone, I'm Yi Quan Chen. I'm a first-year PhD student in surgery and interventional science, working at UB of intelligent neuroengineering, that's called Hubin. And before I start introduce my project, I would like to just give a brief introduction of who I am. I got my bachelor's degree from the Xianzheng Law School and get my master's degree from the University of Bristol. Both degrees are focusing on the data science and AI, which gave me very strong foundation in the the machine learning, data analyzing, and AI-driven problem solving. And you know my work is why I'm here, because in previous studies I have collab with some people with interdisciplinary project, and I realized that the AI becomes especially meaningful when you connect to the real-world human problem. So that's why I decided to apply the technique I have learned to the field of the brain-computer interface. And outside of work, my biggest hobby is gaming. You can see that is only a small part of my game library. I really I play almost all categories games, but I really like simulation games, roguelike hardcore games. Also the project. Yeah, my project is called AI adaptation for the HD, DOT, and FNIRS based on brain-computer interface for stroke rehabilitation. And the central idea is very simple. If every stroke patient is different, then the brain-computer interface, or called BCIs, should not behave like fixed, one-size-fits-all devices. It should learn and adapt the patient over time. And the clinical background for the stroke rehabilitation is that the recovery after stroke usually takes very long and repeated process, and the patient we got is just get very greatly differ from their their injury locations, their movability, and also the pattern of their signal also different. And the BCIs offer us a possible solution to decode their brain signals into the feedbacks or what's it called, or the control signals to the other devices to help them to get rehabilitation. And but they also have some unmet challenges. Is that right now all the decoders are not adapted enough, which means they train on maybe one or several patients, but for the new patients, actually the decoder is just get very bad performance, and just because maybe they have different autonomy, and maybe they have different recovery progress, and also they have just, let's say, different patterns. And even for the same patient, the signal may drift over days, weeks, or months. So the aim of my project is to develop a AI-based method that can to improve the cross-subject subject performance, and keep the decoding results for long-time rehabilitation. So and here I just my project is about what can I say is because I'm in the first year, it's a very early stage of the PhD. So this side only focuses mainly on what I have done right now. So I'm looking for two possible solutions. The first one is the meta-reinforcement learning. In short, it can just teach the model how to not just trained on each patient from scratch, but it's just learn how to adapt to each patient, which makes it less complication for each person. And the second is just simple reinforcement learning for the long-term rehabilitation. Is when the sensor or the patient occurs some problem like the sensor is drift or the patient have recover much better, and the reinforcement will teach the model when to upgrade to fit the right now demand. And so the takeout of this slide is that AI can just make the non-specialized more reliable across the people and across time. And that's all. Thank you. Any questions?
Thank you very much for your talk. I just wanted to ask about what different AI models that you've used and the different types. So obviously you're talking about adaptive AI, but have you experimented with like different types of those?
You mean different type of architecture or?
Yeah, different types of architectures or different builds of AIs.
Right now I'm considering using the CNN, but actually one college I tried like just using it to process the raw signal, but also like my colleague showed, they had to do some reconstruction, just they can show the whole brain with the colors like red or like blue to show the like hemodynamic changes. So maybe I will call it using some like VIT to use as just consider as a vision task.
At the moment you're talking about using this in stroke patients, right?
Yes.
Do you think this has applications in other upper motor neuron diseases or in other patients with different types of injuries and conditions?
Yeah, of course, I think it should be, but actually, most of my literature review I read is about the stroke because, you know, there are many of them, so it's easy to collect the data. So I believe for us, I like maybe people that may lose their limbs, so they can just plug with electric arms, and also maybe this frame can also adapt to them.
And now our last speaker, please can I call Monit to the stage? Thank you.
So hi everyone, I'm Monique. Thanks for inviting me and also thanks for still being here. I appreciate it's been a long day. So apologies, I wrote this during the heat wave, so I might ramble a little bit. I'm an orthopaedic registrar in London, currently in the first year of my PhD, and I thought this picture was quite fitting. So this is a bit about me. This is my first birthday in 1995, where that summer apparently hit 35 degrees, hottest summer on record. I think in the last 30 years, London has not learnt to cope with the heat. So over the last 10 years, I would probably say I've done sort of a graduation tour of London, mainly to assess who has the best snacks. Special mention must go to George's, who had great free wine at my medical school graduation. The Royal College of Surgeons probably had the best snacks, though. I'm excited to see what UCL will offer when I finish my PhD in a few years' time. So a little bit more about me, I guess. My hobbies include netball, traveling, and last year, after recovering from multi-ligament knee injury, I successfully managed to make it to Peru, where I made some new friends along the way. And that's kind of the reason why my PhD and my interest in orthopedics is very much still present. So a little bit about my project. So returning to sport after total joint arthroplasty is not well researched. Most people who were having hip and knee replacements were significantly older, so the demand on what they were asking their joints to do wasn't quite as high. Unfortunately, that is changing for a multitude of different reasons. This is what you see when you Google hip and knee replacement. Probably a lot of private companies in America. As any of you who worked clinically will know, this is not always the case. We know that 10% of those who undergo a total knee replacement have issues. 10% of those end up having further surgery. So we also can hypothesize that younger patients do return to higher activity levels. In the past, younger patients who wanted to return to competitive sport used to get different types of operations. They used to get hip resurfacing. This had a multitude of issues, which we won't go into now. But looking at total joint replacement and total hips and total knees, we don't actually know what our patients do, and this is looking at the UCLH population in particular. So the aims of the study are to quantify what level of sport our patients are returning to, particularly those that played sport before, to find an objective way to measure their performance, and show that we can have people returning to high-impact sports, because in the past we've always said to them, actually, you shouldn't do this. You're going to wear out your joint. You don't want another operation. But that's not what our patients want. And the reason it's so important, I've touched on it already, is we have a younger population who are needing joint replacement. This is a multitude of us expecting more from our joints, like myself. I will need a knee replacement probably in about 5 to 10 years' time. Who knows? And also, we have other issues compounding this. So, for example, obesity is pushing people to have osteoarthritis at earlier ages and requiring hip and knee replacement much, much earlier. So this is what we want our patients to be. We just don't know if we're quite there yet. So I'm going to talk a little bit about the retrospective aspect of my project, because that's been completed. So started with a literature review and a study looking at observational data from patients who've got a minimum of 5 years follow-up. So this is all based within UCLH. So we looked at UCLA scores, which we're quite lucky because we collect those pre and post joint replacement because we're a big teaching hospital. I also did individual interviews with 127 people who implied that they played sport pre-op. Quickly learnt that that was maybe not accurate. And this showed that of 557 patients included, the average age was pretty low, 64.3, which was surprising. 317 had a hip, 240 had a knee. The post-op UCLA scores, so that's the 7.5, 7.62, 7.14, 7.29, were higher, which implies that they were more active, however, not significantly. So I think this needs further work, which is what we're hoping to do. So moving on, we are in the process of setting up a prospective study. The way that we're going to objectively measure this is looking at gait analysis. So we're quite lucky at ICH. We do have a Vicon system, which is not very well used. So I spent the last couple of months working out how to use that. Pretended to learn to code. Has not gone well. But this is what I will be doing over the next couple of years, is looking for an objective measure to see if these patients are actually returning to their baseline, which, as I'm sure you can agree with me, is super important, because a lot of us will end up in this population of patients as we get older, and I don't feel happy saying to my patients, look, you know what, you can't run anymore, you can't play rugby, you can't do this, because it's just not what you have a joint replacement for. And finally, I thought I'd include some of the activities our patients are doing. So interestingly, there were 2 people who took up triathlon. The scuba diving stayed the same, and skydiving, no one wanted to do that after their joint replacement. So 73% of people said that they did return to sports and they were happy, or return to their baseline activity and they were happy with it. However, a lot of them also said that they didn't do high-impact sports because their friends didn't do it after a hip or knee replacement, therefore I didn't think it was sensible, despite us not giving them any restrictions. So we will see. Thanks. Hello.
2 questions.
Go for it.
Your retrospective study, how
Yeah.
far back did you go? How long?
So 9 years. Yeah. Yeah, so it went back 5 years and then went 4 years after that, so that we had a minimum of 5 years data, but some of the patients were up to 9 years.
And but more importantly, did you have any idea about which arthro classes?
Yeah, sorry, I didn't include that in here. So we just looked at hip and knee, primary hip and knee.
Whose hips and knees?
What do you mean?
Which manufacturers? Which makers?
Oh.
Design?
No, I didn't include that specifically. We do use mostly Stryker, so I looked at a lot of Profidad's patients. The majority were Stryker. Yep.
Are you considering any intervention to make them look like?
Not currently. At the moment, looking to see if we can get some objective data, because the UCLA scores were quite interesting. So those that came from sort of higher activity backgrounds probably went back to doing a lot less, but if you ask them, they're like, oh yeah, no, I'm doing amazingly, I'm doing really good, I've done everything I wanted to do before. So I think they were much happier with a lower level of activity, which I thought was quite odd. So I think at the moment we're just looking for something objective, hence the reason for adding gait analysis in there, just to see if we can get people back and ask them to run on a treadmill to see how they do.
Yeah. Have you spent any time looking at the patients, like surrounding factors? So, like, for example, what I've seen a lot is that patients who are more affluent tend to get physio on private, and so their return to sport tends to be much easier, which might not actually have anything to do with the type of surgery or...
Yeah, no, it's quite interesting actually, because this period obviously included COVID. So there's a lot of it that we've had to exclude from some of these results because it's not reflective. So those over COVID had much poorer outcomes, and it was exactly that. It was lack of access to physiotherapy, because often they'd have one virtual consultation and they were never seen again. And we've noticed a lot of them coming back to clinic, and they're the ones with stiff knees, things like that, that at the time it was necessary, but we have seen the impact of that, obviously now, like 4 years down the line. So it's quite an interesting one.
Thank you very much for your talk. So that concludes all of the speakers we have for today. Thank you very much for being here. And we're going to have another 15-minute break now. So we'll see you just after 3. Thank you.
Just if you need a reminder for the titles of the talks and the names, there's a sheet here at the front for the voting.
Okay, can everybody hear me? Yes. Welcome back. So firstly, thank you very much everyone for staying to the bitter end. Before we go on to announce the award winners for today's session, I've got a very special prize I want to award. Every year, when it comes to the Board of Examiners meetings, we get the opportunity to nominate from the Master's Project students the best project that's related to either orthopedics or musculoskeletal science. And there's a special prize in memory of Professor John Scales, who was the founder of the Biomedical Engineering Department at Stanmore, at the Royal National Orthopaedic Hospital. Now, Professor John Scales had many, many accomplishments, so you can Google him afterwards. But some of his more notable ones was he was the creator of the first massive hip implant, which obviously we've been hearing a lot about these kind of joint replacements today. And also the airstrip dressing. So if anybody's ever had an elastoplast, so he's got a really broad range of biomedical engineering. And as part of that legacy, every year, we award the best project, the Professor John Scales Prize, which comes with a certificate and a modest cash prize, which will be sent to the recipient. So, with no further ado, I'm really pleased to announce that Maria Graui was awarded the prize for her work looking at a haptic syringe device. So you can see the full citation here, which really has a possibility to make a real genuine impact for improving patient outcomes in the long term. So as you've heard today, we've had a lot of surgical simulation and training for clinicians, and I think that this project could be really impactful going forwards. So, Maria, would you like to come up and accept the certificate?
So the best undergraduate presentation goes to Tracy G. The best postgraduate thought presentation goes to Ainsley Stewart.
Congratulations, really well deserved.
The best postgraduate research presentation goes to Anna Heller-Zabo. The best poster goes to Dima Alobaidi. The People's Choice Award for Best Presentation goes to Philippe Benedict. And People's Choice Award for Best Poster is Li Hong Shu. think all of you will also get some money in the post. Well, congratulations, everybody. And it's been a really delightful and exciting day, at least for me.
Yeah, thank you. I think there might be some slides that we just whizzed through there. So I just wanted to say a huge thank you to everybody here for participating, because this day wouldn't happen if you weren't here presenting your work, asking really imaginative and informed questions. I think the quality of the Q&A session says something about the presentations, but also something about the audience here as well. And obviously this wouldn't have happened without Jayant, and particularly Sean. Thank you very much. Let's have a special round of applause for Sean. Have you? Okay, and also to all of the students on the organising committee and who have been chairing the session so well today. It's not an easy job. We've had to cope with all sorts of technical surprises and people who don't turn up and running microphones in and out around. So it all adds up to making this a huge success. I think we'll all agree that Mark's presentation was very interesting this morning, and he made you work for it. So he came with a real problem, and I think he went away with some good ideas and some potential collaborations as well. So I think he's really happy about having come along. And also thank you to all of the judges, because that's such an incredible job. I think everybody deserved the prize who presented today, but the judges have to kind of look at that tiny little bit of difference from one to the other. So I think that might be the end of the main slides. We do really appreciate your feedback, and as I say, this Symposium's been going on since 2019. Every year it's different because we listen to your feedback and we make changes, and hopefully it makes it bigger and better each time. So please do take a moment, scan the QR code, which I'm in the way of, I think, and give us your feedback, and thank you so much for participating. Wishing you all a wonderful rest of the week, and see you all around. Enjoy. Bye-bye.